today's webinar on World Arthritis Day. As you all know that there are only two things in the world which cripple you, either the arthritis or the poverty. Poverty you may be able to tide over or not, but arthritis you can definitely tide over with medicines or surgical interventions. Medical science is so advanced that you may rarely see a person limping, walking on the road because of arthritis for a long time, because definitely he approaches a doctor, gets a proper treatment, medical as well as surgical, and gets back to normalcy. That is the magic of today's advanced medical treatment. With this note, I request our president to give his presidential address.
Thank you, Dr. Girish Lad, and a very good morning to all of you. This is going to be a very interesting webinar. We have got an array of speakers, specialists in their own field. So we have got arthritis being covered from head to toe. That is the knee joint, the foot and ankle, the hand, the wrist, and also the spine in a way with rheumatology coming in. So we are going to cover all aspects of arthritis today, and I'm sure this is going to be a very interesting webinar. Friends, just a very important announcement to be made. Of course, Dr. Howard will dwell more on that, but just to confirm that we have reduced our membership charges, and I really request all doctors, those who are not members of IMA, to become members of IMA at the earliest, because it is so important. I'm sure Dr. Howard will tell more about this, the benefits of the becoming member of the IMA. Friends, we are going to have webinars on this month, next Sunday, and even after that, being Osteoporosis Day. So keep on logging in with IMA every Sunday, and happy enjoying CME of this today's webinar. I hand over the mic to Dr. Anil Howard to carry on.
We are going to start on the 1st of November, vasectomy center.
Yes.
So about that, I think we can show that video if you can ask Anil.
Dr. Howard will be doing that.
I'll show it after this lecture.
Yeah. Yes. Oh, okay.
Yes. So, good morning, Dr. Rajesh Minhyun.
Good morning.
Good morning, sir.
Hitesh, we remember Dr. Rajesh Minhyun had come for Midtown Medical Association.
Yes. Many years back, Midtown Medical Association. I don't know if Dr. Rajesh Minhyun remembers.
2001. I do remember. And
I'm
going to start with that. 2001, I gave a talk. And what I have actually done is that I showed you a couple of cases there to show how good this joint replacement surgery is. Because I started my practice in 95.
Correct.
About 27 years back. And it was 5-6 years. And I've included the very two first cases that I showed you there.
Correct.
To how they are doing at 20 years.
Yes.
Dr. Howard, please.
Friends, we just begin with this session. The first speaker is Dr. Rajesh Minhyun. Dr. Rajesh Minhyun is a joint replacement surgeon at Sir H.N. Reliance Foundation Hospital and Research Center. He has been exclusively practicing joint replacement surgery for the past 22 years, and he has done more than 7,000 joint replacement surgeries so far. Dr. Minhyun has kept up with the technological advances in this field. He has been one of the pioneers in India in the use of mobile bearing knee implants and computer navigation. Dr. Minhyun is actively involved in various research projects, including more than 30 international publications, and authored several chapters in renowned textbooks. He was the recipient of the Norman Roberts Medal at the MCH Ortho Examination in UK. Two of his innovative surgical techniques in knee replacement have been included in the American Academy of Orthopedic Surgeons. One surgical technique won an award and was shown again to delegates in the recent AAOS meeting in San Diego. Dr. Minhyun is a founder member, trustee and a past president of Indian Society of Hip and Knee Surgeon, and is an international member of the prestigious American Knee Society. Today, Dr. Minhyun will be talking to us on what can you expect in your patients after 1 and 2 decades of total knee arthroplasty, presenting my case studies. Over to Dr. Minhyun.
Thank you very much, Dr. Awad, Dr. Ritesh Mehta, Dr. Lad. I really appreciate getting this opportunity. Are you able to see my screen?
Yes, yes.
Yes, sir.
Yeah, so I think on this World Arthritis Day, I welcome all of you. And I remember I gave a talk in 2001, soon after, about 6 years after I had started as a joint replacement surgeon in Mumbai. And I was trying to say that this surgery is a real good cure for an arthritic patient, because as John Dryden has said, that for all the happiness mankind can gain is not in pleasure, but is in rest from pain. And that is what this surgery brings about. So today, what I'm going to do is show you that how this surgery has fared over the last 20-25 years that I've been practicing. And I've included the very two first cases that I had shown then to show how good this surgery is, to show how they are doing. This patient, X-rays are at 20 years post total knee arthroplasty, and you can see the joints look pristine with a good amount of articular cartilage, no evidence of any loosening or any osteolysis leading to failure even after 20 years. These are mobile bearing knee replacements, which is the one I had started using as it had the least amount of wear and tear. Not only that, this patient was 135 kilogram when I operated her, 98. This is the first lady that I had shown. This is at 3.5 years, the same patient. And here she is 17 years after the operation. The X-ray is looking absolutely pristine. And these are the 20 years. Currently, she's 23 years since I operated her. And both the joints still remain functional. She's still mobile. Of course, with the age, 80 plus now, she is limited, but the knees are not bothering. And I think that is what I wanted to bring up, that not only this surgery is good, it is something that can give you a long and almost a permanent relief for most of the patients if done correctly. And there are certain other factors that brings about this long-term successful outcome. We'll discuss them in a brief. This was the second patient. You know, when I started practice, a lot of patients came with severe deformity, and only those patients came. With moderate arthritis, patients were still waiting to see how the results would be. So this was another patient that I had present at that time, 72-year-old male who had severe disability, was hardly able to walk, not even for his activities of daily living. He needed a lot of support to go to the bathroom as well. And I had presented his video to show that post-surgery, how well he can start being normal. And there were many patients exactly like him then. This is his pre-op video, and this is his 3-month post-surgery video, where both legs now in better alignment, and he had become completely functional. Not only that, he had started using driving, started using traveling by public transport, and started attending office. He was so active that I had to tell him he wouldn't wait for his lift to go up and down the steps. And I said that those days we didn't know how long it is going to last. However, he remained very active. And here he is 10 years and 11 years post-surgery. In spite of being that active, he continued to remain good till he died at the age of 88. Both knees remained functional. I think that is what I wanted to bring up today, that these surgeries have not only shown that they relieve the arthritic pain, make the patient functional, but they do it permanently if done well. The second group of patients that I used to treat then were the rheumatoid arthritis patient, like this lady, polyarticular rheumatoid. Over the 2 years period, I did her both knee replacements and one hip replacement, and an immobile patient became mobile and happy. And these are the 20 years x-rays for the hip and the knee replacement for the same rheumatoid patient. Because I think that was one of the worry that, okay, for osteoarthritis patient, it will probably last. What about rheumatoid patients who have osteopenia and a lot of other issues? But here she is, this lady, 20 years hence, with 3 joint replacement, still remains functional. Similarly, this lady, way back in 97, both knee replacements done, became functional. And here her 18-year x-rays. She recently came from Nepal with a fracture in the hip, but both the knees remain functional. And we've published these results in the Indian Journal of Orthopedics about our long-term results of this mobile bearing knees that I did in the earlier part. At an average of 12.25 years, 98% of the patients were surviving with their implants and using them for function. Then came we had a little restriction with the earlier mobile bearing implant in terms of how much knee flexion we could give them. So we started using a modified implant, which was the posterior stabilized, which gave better knee flexion. And this is a gentleman who had one such implant at 13 years on one side, 9 years on the other side, and he uses it for his regular activities, sitting on the floor, and remains very functional even at the age of 87 with all these implants. He's now completed 20 years from his surgery. So we published this results of the new implants in the American Journal of Arthroplasty at 10 to 13 years. And what I wanted to bring up here is the survival of the implant, this red line. It shows that even at 10 years plus, all the implants survived. All of these patients were extremely active and functional. The other thing that I started doing in the year 2000 was the unicondylar knees. That was a very, very early time for this particular surgeries, which have currently become more popular. However, we started doing it way back in 2000. This is one such patient operated in 2002 for a right indication where there was an osteochondritis dissecans affecting only the medial condyle. And he's a 63-year-old, then good function, quick recovery. And here he is, after 18 years or 17 years, remains extremely functional. And this is at 17 years. Now he has completed 19 years. He's got arthritis in the other compartment, but still continues to have functional unicondylar knee. This is another patient, unicondylar knee, and here at 13 years, continues to remain functional. These are some more. I'm able to see my screen, yeah. So, however, what is most important is selecting the right patient who needs this unicondylar knee replacement, because we see that number of patients come back in a year or 2 year or 3 year for a redo surgery. One such patient, 43-year-old lady who had a unicondylar knee replacement. The surgeon overlooked the lateral compartment arthritis and the patellofemoral arthritis, and in just 2 years, we needed to revise that. Here it is a revision with a mobile bearing implant, and there she is 10 years after the revision of a unicondylar, in just 2 years, remaining functional. This is another lady I recently did this lady, just 1 year back, she had a unicondylar knee replacement in a knee which was very, very severely arthritic. And I probably, even in an elderly patient, doing partial knee replacement, if it is not correctly indicated, will only result in requiring a revision surgery. So in just 1 year, the severely arthritic knee, which was operated with a unicondylar knee replacement, had to be revised. There's no way she was able to walk with this device. So we revised it to a total knee, and she's back functional now. Yet another patient, although was a right indication to do the unicondylar knee, these are extremely technical surgeries, and the slightest malalignment leads to failure. So this lady had a failure in just 2 years, and we needed to revise that in just 2 years after the unicondylar knee. So I think unicondylar knees have a special place and a good results over the long term. However, the case selection and the surgical technique are extremely crucial. Another technology that I adopted in 2004 was computer navigation. The reason for that is that malalignment in joint replacement, the surgeon had put this joint in a varus. You can see that the tibia is remaining in varus, and in just 5 years, it collapsed onto the medial side. If the pillar is not correctly aligned, it's not 180-degree vertical, it's going to fail at some point of time. It's very simple to understand that. So I had to revise in just 5 years this patient. This is another one where the surgeon put the reverse slope on the tibia. Rather than the posterior slope, it was reverse anterior slope. That makes it very unstable. And this joint was unstable. And in just 6 months, I had to revise that. So malalignment means problems, and the proper alignment means better outcome, not only short-term function, but even in the long run. And in total knee, alignment means aligning your knee to the hip joint and the ankle joint. And that's where the critical importance of computer navigation comes in. That when you're operating a knee joint, you expose the knee and you have no idea where the center of the hip and center of the ankle is. And you just take a guesswork using your conventional instruments. Whereas with computer navigation, not only you know this complete mechanical axis, but you also know the individual alignment of the femur and tibia, not only in the coronal plane, but also in the sagittal plane and also in the rotational plane. How it works is that there are some arrays that are fixed onto the bones, and then we do certain movements and record the patient's anatomy into the computer. Just as you start the operation, now the computer knows exactly the patient, where the femoral head is, ankle is, and the other anatomical landmarks, and then it guides you to do the surgery. And even such severe deformities, you can see completely disorganized joint in a young patient were operated using computer navigation with a complete correct alignment achieved at the end of the surgery for both knees. And here she is 10 years post-surgery. Joints not only look good, allows her to have completely normal function in terms of walking, climbing, bending the knee, and even sitting on the floor. What computer does is that even if there are significant bowing on the femur, which you can see here, it will help you to align straight the hip with the knee. The right knee, which you're seeing now, was done by another surgeon using a conventional technique, and you can appreciate that the femur remains in the varus alignment and overall leg alignment is wrong. Whereas on this side, where we use computer navigation, we've got correct alignment with a horizontal joint line. This is not only going to give a better function, but allow it to last for a long time. And the literature has shown that time and again that the computer has produced better alignment in each and every study. We also published one such study in American Journal of Arthroplasty. And it was a unique study because it assessed the margin of error in alignment when a study was undertaken when I converted from conventional to computer-assisted total knee arthroplasty. And what we found that the conventional technique in our patients was 82% accuracy. accurate in getting the correct alignment. But there's such a wide variation when people use conventional technique. An experienced surgeon at the best can achieve 80 to 85% accuracy using conventional technique. But on the other end, if somebody is not very experienced and can achieve only about 50 or 60% accuracy. Whereas with computer navigation, even when we used it in the first 100 patients, we had 94% accurate alignment for each individual component. And with experience, that means we looked at another cases after 500 cases and we became 100% accurate. Each and every patient had correct alignment. And I've been using computer navigation since then. I've done overall 7,000 knees, 5,000 plus with computer navigation. And now we are moving on to the next, which is the robotic surgery. My colleague friend is going to talk about that later. But I would say this, that the robotic surgery is only a step forward because it is 90% computer navigation that we are taking it further, which is a completely proven technology over the last 15, 20 years. Also, it makes it easy for those who adopted to computer navigation to adopt this new technology, which is going to give you that 5 or 10% more to what we achieve with computer navigation. However, like all other technology, it is still refining and needs to refine to a stage where we can minimize the timing and complications with that, and that will soon happen. With navigation technology, what it also helped me was to treat some of the complex cases like this extra-articular deformity in a doctor himself, which occurred because of the supracondylar fracture in the past, and ideally would need two-stage surgery, one to correct the deformity and second to then do a total knee replacement. Being doctor and a busy, didn't want that sort of two-stage surgeries and prolonged recovery. Computer helped me do it in one stage by making a very special accurate cut of to preserve the ligament around and put a mobile bearing implant. Here is the post-op X-ray, correct alignment, and he is here at 8 years post-surgery with good function. And here he is 10 years post-surgery. Currently it is 12 years. Another extra-articular deformity patients with multiple osteotomies done in childhood, both on the femur and on the tibia side. On the first, you think that this is, how are you going to be able to correct this? With the help of navigation, you can achieve it correctly. Second leg operated, excellent function restored, and she remains functional at 10 years. I also wanted to touch base upon revision surgeries, which we started doing from 2008 in relatively large number, and you can see that the numbers are only increasing. There are some myths about the revision surgery, that it is not successful. It will give only a very limited function and does not last. Let's just quickly look. It is basically needed when there is an early failure in infection, malalignment, instability, or stiffness. In late cases where there is polyethylene wear and loosening because of the sepsis, either osteolysis or osteoporosis. Show you a couple of examples. Infections, we normally do a two-stage revision. Here is the patient who had a total knee infection. The primary surgeon did first surgery using autoclaved implant. It failed, which is when I saw the patient, we did a static spacer to get rid of the infection, all the infected bone, and then re-prepare it to clean bone to receive the special implants. And here at 1 year post-surgery, you can see the function. A similar function as a primary knee. Also, we started using articulated spacer to give them a function during the interim period where we do it in two stages. Here is a doctor from Indore who had bilateral knee, had both knees infected there. Here we did surgery in two stages, putting articulated spacer. 2 months post, one implantation, one side is still articular spacer. He's able to bend and walk on that. Then we did the second, and he's 1 year after the surgery, back to normal functioning. We controlled the infection and got him back to be functional. And these are some other patients, 10 years post-infection. So you can get a long-term survival after treating infection, although it is a very, very tedious and very involved process to achieve control of the infection in a total knee arthroplasty. And they retain good function. Here is this patient 4 months post revision surgery for infection and 7 years post, remains infection-free and good function. Long-term wear, these are some of my patients. I had done the primary knee in a young patient way back in 2001 and 1999. After 14 years, she wore out her plastic, and that had started causing osteolysis and wear. She was still able to walk, but with the amount of osteolysis, I explained her and did the revision surgeries. This is immediately post-surgery, and now 10 years hence, she continues to remain functional with the revised joints. And I would expect this to last another 10, 15 years. Yet another patient, again, I had done, she was a very young patient then, 45, needed a total knee. In 10 years' time, she had worn out with the extreme use. And we know that those eras, plastics were different, and some of the particular plastics involved wore out faster. But at 9 years, I revised her, and today, 10 years later, she remains functional and active. Not only that, we started doing some multiply operated patient. This patient had a total knee infection. The primary surgeon did a revision surgery, which failed, another surgery, which failed, which is when I saw him. We decided to do it in a 2-stage, control the infection, and then put an implant. He was an elderly even then, but improved well, infection control, became functional. Here he is 8 years post-surgery. Another patient, multiply operated patient in Africa, UK, and almost was advised by amputation by many on the left knee. We found a bug which was controllable and decided to give one more go, and we could achieve an infection control and a good function. Another lady, a long story, young patient, bilateral HTOs. In 3 years or 4 years, because she did not have good relief, bilateral total knee replacement, one after the other. 10 years, she wore it out, a young patient again, extremely active. We revised both. She's back active. And this is 11 and 12 years after that revision surgery. She continues to remain functional. So revision knee replacement surgery can be successful. The function remains comparable to primary total knee. And with today's implants and technique of mobile bearing revision implants, survival also remains comparable to the primary total knee arthroplasty. Finally, I'll end with this. What is our current aim? Current aim is to achieve pain-free period after total knee arthroplasty in the recovery phase as well, reduce the amount of pain that they used to undergo, rapid recovery, and allow them leisure activity. Some of our patients, these are bilateral total knee replacement patients, can easily kneel, do yoga activity. You can see her knee. This is a patient with bilateral total knee arthroplasty doing Surya Namaskar. So these are all possible with the advance in technology, the technique, the implants, and we could allow them with a good confidence that we are going to have a good survival in these patients. Here are some of the other patients doing the other leisure activity that they would like to do. Patient doing their dancing activities 10 and 12 years after the surgery of both knees, golfing activities. And one of this other patient, just 3 months after bilateral total knee, did a cycling total journey of 372 kilometers. I think that is the aim today. Good function, allow leisure activity, but at the same time have a long-lasting outcome. Probably in another 20 years, I'll present this patient's results. Thank you very much for a patient hearing. And I wonder if there would be any questions I can take.
Thank you very much, Dr. Minhyun. It was really an excellent presentation, and we could see what so far you have done in the last 20 years. And hats off to you. Thank you very much. Sir, I think there are no questions.
So I just want to ask Dr. Minhyun.
Yes.
Yeah. So after reciting your so many years of experience, like when you look back, how do you feel? You know, personally.
I feel great. I think I remember that in my as I was doing my orthopedic surgery and thinking of specialization, I read a book from Sir John Chanley, who's really the pioneer in the world for this hip replacement surgery. And he said this, that if you want to get the best out of this surgery, you need to dedicate yourself completely. And that is when I decided that I'll not do anything else and spend time only in this particular surgery. And I think I feel happy that I did that, because I've been able to deal with different types of problems in the arthroplasty and get myself more and more trained and achieve better outcomes. So I think I am very happy that I chose this field.
And rightly so, because I think 25 years back, the concept of a super specialization or a person focusing on a particular part of the body was very less that time.
Yes.
I think that has led to your dedication and your perseverance in that field.
Yes.
Nowadays, of course, we see so many super specialists, but in those days, doing only one part of the body, that was very...
So the thing is that the joint arthroplasty surgery is a great surgery. And the moment you put something between the two arthritic bone, there's going to be a pain relief. But the question is, we need three things achieved. We need to get that 70-80% result, which is going to happen even with a surgery which may be slightly malaligned or slightly not stable enough. But to take it to the 100% is something where you need dedication and really effort, not only from yourself. You need your team around, you need your physio, you need to follow up, you need to ensure pre-operative check to make sure that infection doesn't happen. So I think to just get the best, to make that 70% result to 100%, you need to dedicate yourself.
Yes, make perfection. Absolutely.
Sir, one question has come. How do you compare robotic surgery with routine surgery in orthopedics?
So I think it is a great step forward, the robotic surgery compared to the routine surgery. However, the routine surgery has evolved. Routine surgery has gone through the first major step of evolution with computer navigation, which changed the alignment completely. And because I used to do routine surgery till 2004 and I switched to navigation, I know that how the results have changed. The robotic surgery is actually 90% of the navigation. So if you compare with the routine surgery, it is a great step forward. But if you compare with the navigation, it is a small step forward. And I think for the surgeons who did navigation, it is only a natural thing to start using robot. But as I said, the robots are evolving. The initial technology burred the bone, which was not very good. Initial technology took the partial knees as the first layer, this thing, then a total knee. So I think it is a technique which is evolving, and you need to balance both the plus and minus. It's a great step forward compared to routine surgery, conventional surgery. Compared to computer navigation, it is almost at par or slightly better.
Definitely, sir. Thank you very much, Dr. Rajesh Minhyun.
Pleasure.
It was really an excellent presentation. Thanks a lot.
Thank you very much for the opportunity. Thanks.
Friends, now we move on to our second lecture, and the speaker is Dr. Pradeep Noth, I'll just introduce Dr. Manoj.
Dr. Usha is there?
Yeah, I'm there.
Okay. Good morning, Dr. Pradeep Manoj.
Good morning.
Good morning, sir. Now, Dr. Pradeep Munot is a consultant orthopedic and podiatry at Sir H.N. Reliance Foundation Hospital and Research Center. After passing MBBS from St. G.S. Medical College, he did MS Orthopedic from University of Mumbai with a silver medal, followed by DNB in orthopedics. He then completed membership of the Royal College of Surgeons, MRCS from Royal College of Surgeons, Edinburgh, and FRCS Trauma and Ortho from Royal College of Surgeons, Edinburgh. He received AO Trauma Fellowship with Professor Alonso Birmingham, USA. He is the only knee, foot, and ankle specialist in the country and have more than 15 years of clinical and research experiences in the orthopedics and in both UK and India. He has been trained at leading orthopedic pediatric centers like UCLH, London, and centers from largest number of joint replacement in UK. He has worked with pioneer of knee replacement like Professor Michael Freeman. He is the faculty member on various courses and conferences for knee replacement and has more than 50 international and national publications and presentations to his credit. His specialty and area of interest is sports medicine, foot and ankle surgery, ankle arthroscopy, complex foot trauma reconstructions, hallux valgus, bunion, plantar fasciitis, hammer toes and cones, Morton's, neuroma, and flat foot. Today he will be speaking on arthritis in foot and ankle joint. Over to Dr. Pradeep Munot. Thank you, sir.
Thank you so much. Can you see my screen?
Yes, yes.
Yeah, thank you so much. Thank you, IMA, for inviting me and organizing this talk on the World Arthritis Day. I'll be talking on arthritis in foot and ankle. I know a lot of people heard about other joint arthritis, especially knees and hips. So what I'll do is it's a very complex joint in the foot and ankle. We have 26 bones, 33 joints, and more than 100 ligaments and around 19 muscles. So you can imagine if you look at the foot, you have the hind foot, midfoot, and the forefoot, and you see the number of bones are phenomenal. Now, each of these joints can have arthritis, and the arthritis, the burden of foot and ankle arthritis is humongous on the society, where almost 70% of the people will have disabling pain because of some form of foot and ankle arthritis, which leads to limitation and impairment of their mobility, leading to imbalance issues, which ultimately may lead to falls and causing fractures both in upper limb and the lower limb, especially the hip area. Especially if it is in younger patients, they have reduced ability to work, thereby affecting their income as well and the family support. And in a general family physician type of picture, it is a common cause of family physician consultation, and in musculoskeletal, it is around 8 to 10% patients who come with foot and ankle arthritis with the symptoms. So what are the causes of the arthritis? Of course, we know the fact in knee, it's usually the age related, but in foot and ankle, that may not be so, especially in the Indian population we are talking about. The common causes is in India, we have post-traumatic where there is a damage to the joint surface, which ultimately, if it is not treated properly or not reduced accurately, can lead to an arthritis. You can have a cumulative trauma, like a patient who have lateral ankle instability, and over a period of time, because of the micro trauma to the joint surface, can lead to arthritis. Age-related attrition. We know the fact that in India now we are seeing the lifespan of the patients are increasing. So you get very common patients of 70 and 80 coming into your clinics walking, and those patients could have primary osteoarthritis. Rheumatoid arthritis is one of the other causes of foot and ankle osteoarthritis. Gout is there as well. And don't forget diabetic foot or patients who have had neuropathy in the foot and ankle and foot are very common involvement in diabetic Charcot. If you look at patients, again, this is not an Indian numbers, but this is the Caucasian population. So aged above 50 years and above, ankle is only 3.4%, But symptomatic osteoarthritis, almost 17% involved in the foot and ankle. And there is no question about that. That's because we have so many joints in the foot, you will bound to have arthritis in the foot as well. And in population prevalence, if you look in the foot, you have multiple joints. So I'm not going to go through individual joints, but the great toe, that's a first MTP joint, you can have arthritis. You have the second CMC, TMT joint, I call it. That's a Lisfranc joint you can have, the navicular cuneiform and the talonavicular. These two joints, you can have arthritis either because of trauma, or in Indian population, what I've seen is patients having flat foot, and secondarily, you have arthritis. Again, I'm not going to go through individual numbers, but what you can do is talonavicular, navicular cuneiform, and the Lisfranc joint. You can club these together, and we called it as a midfoot arthritis, a patient complaining of pain in the center of the foot. What I've seen is a lot of patients not being diagnosed properly. So the key is listen to the patients. What is the question, or what are they talking of the symptoms? The symptoms are pain while walking, and after a period of time, even pain after rest as well, or nighttime pain, and stiffness. They are not able to walk freely as they would like to do. And in the signs, so the clinician examination, this is the key thing. And that's where the training of the clinician or the surgeons or the orthopedic surgeons come into play to do an accurate diagnosis, because you cannot diagnose these patients on X-rays, only on X-rays or MRI scans, because they will show so much on these scans. So accurate clinical assessment is the key. Where is the exact swelling is present? Is it in the talonavicular joint? Or is it in the TMT joint? Is it in the second or the first? So palpation, as I said, is a key thing to do it. Check for movements. Individual joint movement needs to be checked. Bigger joints like ankle joints, subtalar joints, talonavicular, you can feel the crepitus where there is a grating sensation as well. Or in the first TMT, first MTP, that is a great toe joint. If you can, what you call as a grinding test, you can feel the crepitus, check for pain, check on palpation, what is the problem. Bigger joints, as I said, again, ankle joint, you can check for the ligament stability and see if there is instability as well in there or not. Investigations, why the key thing is, we know in knees and hips, you take a standing X-rays. Why not in the ankle and foot? Weight-bearing X-rays are must for diagnosing the accurate arthritis and loss of joint space. And the key thing is still 90% of the centers, if you do not write it, they will not do a non-weight bearing. They would not do a weight-bearing X-ray, because in weight-bearing, you can clearly see how much is the space which is lost, what is the kind of alignment which you're looking at. And of course, you look at sclerosis and osteophyte. Those are the normal signs and symptoms of normal findings of arthritis. The second thing which I found in the last 5-7 years, which I've been practicing in India, either physicians or general orthopedic surgeon routinely sending patients with pain in the foot and ankle straight away for an MRI. Yes, and you can see a little bit of wear and tear here, a little bit of joint space narrowing. But ideally, for an arthritic patient or to see gradation of arthritis, a CT scan is a much better evaluation, because it clearly shows if there is any irregularity of the joint surfaces there, if there are any cysts present, how much joint space narrowing is present. All that is much better appreciated, gives a true picture of the arthritis than an MRI scan. MRI scan can be an overkill, can overdiagnose as well. Coming to the management, initially, of course, all patients will go through the medical management. They go through, of course, hot or cold fermentation and NSAIDs. If they have rheumatoid arthritis, then of course, a rheumatologist may start with DMARDs and disease-modifying or advanced drugs like TNF and interleukin-1, which I will not go into the details. But if they've gone through that, then the next stage is injections. And I tell my patient there are two types of injections which now we can offer. Small joints, you can still give a steroid injection, and that also to be in a targeted manner. When I say targeted manner, that means under either X-ray guidance or ultrasound guidance. That is a key thing, because you could be going anywhere and you may not get any good relief from the injection. So it is not the downside of the procedure, it is the downside of the accuracy of the procedure, I would say. And the new things on the block is viscose supplements. We know in knee, it works quite well. But in the ankle also, you can get a 2 ml of viscosupplementation or gel injections that works well. In the last few years, PRP injections have played a big role in knees, but now even in ankle, we know the fact that it works reasonably well with minimal side effects. So along with medications or injections, other forms of supplements which you can do, lifestyle modification. So especially in ankle and subtalar joint arthritis, what I tell my patients to wear a rocker bottom, which reduces the movement in the ankle and the subtalar joint, stabilizes the subtalar, thereby and helping in the rolling over of the body over the foot, thereby reducing pain. Now, if you suppose have a hallux rigiditas, which is arthritis of the great toe, what you could give them is a rigid sole, which will reduce the movement of the MTP joint, thereby reducing the symptoms. Along with this, of course, strengthening exercises, stretching exercises, calf stretches are very, very important as well. So these are all the medical management. Now I'm going to go through cases, and I've not taken everything, but few of the ankle, subtalar, midfoot, and the first MTP joint. So let's go through them. So first thing is a 45-year-old male with chronic pain in the left ankle, twisting injury 5 to 6 times in the last few years has happening, managed elsewhere by plasters and no relief. On clinical examination, you have painful terminal range of movement, which is not restricted. If you clinically see here, the ankle is in slight varus, and I'll show you in the next pictures what I mean by that. And on the outer side, there is pain and swelling and instability is there. And draw test exactly how we do for knee, it's there for the ankle as well, where you can almost get the talus forward and backwards onto the tibia. MRI was done, which showed wear and tear or arthritic type picture on the medial side of the joint. Now, this is what I was talking about, weight bearing x-rays that gives you a true picture of how the patient stands and how the ankle will be. And here you can see how it should be usually neutral of 5 degrees of going outwards, but here it is going inwards and wear and tear or arthritic on the medial side. Now, quite a few people would probably offer him either, so of course, all the conservative measures were done, injections were done, and after that, what options you have? So let's look at the options. You can have arthroscopic debridement. It works better than in knee. Knee, of course, it's almost a no-no now for a arthritic knee, but in ankle, you can buy sometimes 6 months to 1 year or even 2 years you can buy. You can do an osteotomy in the tibia or in the calcaneum to better the alignment. You can do an ankle replacement. Most of the people here in India would probably go for an ankle fusion. Of course, it is a gold standard in significant or worn out ankle. Ankle joint distraction, a few people do it, but it's not predictable results. So this is what we did it, or I did it. Here, because it was only on the medial side, it did an osteotomy of the tail of the tibia, open wedge, and changed the alignment. And here you can see how the alignment is being changed. On the outside, the ankle was unstable, so that also we strengthened the ligaments. And finally, if you look at the pre-op and post-op, see how that alignment was there. This is the alignment, and you see how now there is a symmetrical joint space, and that's the ankle range of movement. Wounds have healed quite well, and they went on to do quite good. So ankle is salvaged. So no fusion and a happy patient. So next patient, a 70-year-old patient, pain in the ankle for many years, limb present, past history of trauma. And you can see here, because of the previous injuries and scar, which he has been getting repetitively infection, and the skin around the ankle is not very good. This is the ankle picture. Now, a lot of people will think, is that infection? So that's why I clearly mentioned bloods were okay. So this infection was ruled out. Now, what did I do? I did an arthroscopic ankle fusion. So if you can see here, so this is not the same patient. I could not find the same, but get the incision. So 2 incisions only, small incisions, and 2 incisions here for the screws. That's all we have. So irrespective of how the skin condition is, you can still do an arthroscopic ankle fusion, and they went on to do quite well. So that diffuses the incidence of ankle fusion, arthroscopic ankle fusion, or the rate of union is much higher, much quicker, lesser morbidity, lesser pain as well. So that's the gate. Now, when people talk about it, when they say, oh, once you do a fusion, and this I'm going to repeat it again and again because I have been seeing patients again and again. Oh, once you do an ankle fusion, I will not be able to walk. I will be limping a lot. And trust me, if you look at a lot of my videos and a lot of videos even on internet or YouTube, you cannot make out sometimes or most of the time which ankle is fused if done properly, if done in a good position, done by I would say good techniques, good position, good surgeon. That's all you need to get an excellent outcome. And you see how much movement they still have. You can't say that. And you see the skin condition, no issues at all. Another patient of 70-year-old, but a significant deformity with a valgus ankle. And she wanted one solution. So I did a open ankle fusion. Now, this is a special ankle fusion place, which is just available this year in India. Costs a lot, but the key advantage is you can get a good compression of the ankle of the fusion side. The incidence of fusions is quite high. Position is very good. But if you see this, there is no plaster. So after the surgery, she was left only in a Gamgee, and she was allowed to mobilize her other joints, the toe joints and the midfoot joints right from day one. So no cast was required because the fixation is so stable. So advantages of open ankle fusion done properly again. Next patient, again, a 56-year-old lady, pain in the ankle, difficulty in walking with a rheumatoid arthritis. Now, she already had a triple arthrodesis done before. Now, pain is spreading into the other joints as well. So, triple means where the subtalar and talonavicular were already fused. Now, you see how the ankle is arthritic, and of course, the deformity as well in the varus. You see that? Now, either you could do an ankle fusion and lead to a pantalar fusion and give a very rigid hind foot and a midfoot, or we could do an ankle replacement. Again, that's an option of doing single stage or two stage. So it was done in two stage. First, implants were removed, and once everything was healed, she went on to have an ankle replacement. Alignment 3 years post surgery, and alignment is good. I'm sorry, the video is not working, but good movements in the ankle. And because the midfoot and the hindfoot, the subtalar joint was already fused, even some movement in the ankle is a bonus for them. Now, rheumatoid arthritis of the foot, 50% of these patients will have a foot and ankle problem. And usually it's a subtalar joint and the midfoot joints which are involved. And sometimes what we find is an isolated talonavicular arthritis may be one of the earliest findings with rheumatoid arthritis. Next case, a known case of rheumatoid arthritis, 56-year-old lady, pain while walking, and she's been suffering for 2 years, tenderness only in the subtalar. You can see how the normal side, and this is the outer side, the subtalar sinus tarsi area, there is swelling and pain. Had an MRI done, already sent from Air India with an MRI, and you can see the subtalar joint is quite arthritic, a lot of cyst present. She already had 2 injections, and this was under CM guidance. This is what I mean, targeted injections. You cannot be injecting in this area just to get a pain relief and for diagnosis. No, you need to make sure these patients are taken into the operation theater and make sure that CM guided injections are done to get maximum relief. Finally, she had a subtalar fusion done, and this is 2 months after the subtalar fusion. Look at that. Which side was it? I don't know. But she's a happy bunny. And then she had, within 3 months, she had to join her work. And being an air hostess, she has to do the evacuation. She did all that, and she was back into active duty. And happy patient. Another patient with a calcaneum fracture. And you can see here, the calcaneum is completely trashed out, bottomed out. Big spikes on the bottom as well. So this is a malunited calcaneum fracture. If you look at the alignment, this is the ankle joint, which is quite good. This is the talus. This is the calcaneum. So calcaneum is literally under the fibula. So she had pain. She had unable to walk. She was literally jittery while walking. So opened up through a big extensile approach because everything had to be relocated back and alignment had to be got. A bone graft was done to get the height. You see how the height has been completely lost. The talus is abutting against the tibia. So these are all the things which we have to look at when we need to correct a deformity. These are just not a fusion straightforward, open it up and fuse it, prepare the joint. No, a lot of things go into the planning before a surgery has been involved in, especially in foot and ankle. Because if you don't get it right, the patient will not be able to put the foot flat on the ground with the body vertical. And finally, she had this, look at this height. Now there is no abutment against it. The hindfoot height has been increased. Alignment has got better. This is the calcaneum under the talus. Next case, again, isolated talonavicular arthritis, which she finally had a fusion done, only an isolated talonavicular fusion done very well. So triple fusion, when we talk of either patients in rheumatoid or patients in flat foot, where you do a fusion of the subtalar joint, talonavicular joint, and the calcaneocuboid joint. Now, in the last few years, I have got a lot of patients coming to me and saying, oh, if I do a triple fusion, then will I be able to walk or not? Now look at these two patients. I purposely kept two patients. This is she herself is a gynecologist. Look at her. Now tell me which side she has had a fusion done. We don't know. They walk quite well. Only on uneven surfaces is a slight problem of balance. Otherwise, they walk quite well. They need, of course, good footwear, but that's not an issue. What they were not able to walk even for say 5-10 minutes in the kitchen. This lady, she is 75, lives alone and does everything by herself at home. And even this, she lives with her husband and she's managing quite well. And these are 3 to 4 months post-op. These are not 1 year, 2 year. Midfoot arthritis, of course, conservative treatment. I've spoken about steroids, physio, and orthosis. These are one of the few things where you do targeted injections with contrast. And if beyond that, if 2 times the injection doesn't help, then a fusion can be done. So again, a midfoot arthritis with plates and screws. Just last few cases. Okay, pain, middle-aged lady, pain in the great toe. Now you see this. Arthritis is there, not very bad, but there is arthritis. She's not able to wear shoes, tried all conservative. When I say conservative, physio, painkillers, orthotics is done, and injections. And here you can see how there is a big dorsal osteophyte present. And this is what options are either. And again, I think most of the people here would do a fusion, but there are other options as well. And I'll talk about it. You see how the great toe is not going up further. It's just around 20 degrees. In India, if you look at everybody, look at your great toe, you will probably have almost like 45 to 60 degrees of dorsal movement. Because of that big bump here, they do not have the dorsal movement and they get pain, especially if the females, they wear a little bit of heels. Open it up, you have a segmental type of a little bit of arthritis, but the rest of the joint looks quite good. That's your dorsal osteophytes present. So we just take an osteophyte, a little bit of cartilage you take off the osteophytes, and then you have a good decent articular surface. So you do not need a fusion. Now the other thing which people did not notice is the first metatarsal was quite long, and that was probably the cause of arthritis. So again, understanding what is the primary cause of the arthritis is important in your assessment. And here you can see the metatarsal head was shortened and then fixed. And now you can see how the parabola of the foot is nice and clear. The joint space, you can see nice now, clean, and she went on to do very well. Now, last case, 30-year-old male, pain in the great toe since many years and known case of gout. Now here you can see how bad is the gout. The joint is completely destroyed. But the other thing to notice is the first metatarsal, the ray, is quite short. Okay. Now, of course, you can do a fusion, but what other thing which you need to understand is you need to get that height. You see the difference in the height. Now, if you just do a fusion here, there will still be a big asymmetry between the first and the second toe, and patient will have callosities, cons, and other issues as well. So just not fusion, got the length out, put a bone block inside here. This is the size of the bone block, almost 2 centimeters, I would say, and got the height back. Now it's much better and a happy patient. So in conclusion, listen to the patient's symptoms carefully, understand what the problems are, what is affecting their activities of daily living. Examination is the key to get a good diagnosis or proper diagnosis in foot and ankle world. Get weight-bearing x-rays. Do not compromise on non-weight-bearing x-rays. Multiple modalities of medical management need to be aware, and targeted injection, especially CM-guided injections, are key. Recent advances, especially PRP and bone marrow, does play a role, especially in larger joints like ankle. And surgery done appropriately with careful understanding of what is the outcome gives excellent outcomes. Thank you very much for listening. Questions?
Yeah.
Thank you very much. There are no questions in the question answer box. Any question from the panelists? Dr. Usha?
Yeah, sir, accidental arthritis of the ankle joint and the deformities can be corrected totally.
So again, as I said, I showed you in two of my cases. Yes, it depends on the deformity, how bad is the deformity and how bad is the arthritis. So proper counseling of the patient, what are the expectations and what they want out of their joint is very important. But yes, I've had a lot of patients in the recent time also, again, ranging from patient age 30 to age 70, where we have been able to salvage the joints by doing a proper assessment and doing adequate surgery, I would say, depending on, say, arthroscopic debridement plus bone marrow injection plus a supramalleolar osteotomy. Yes, you can save the ankle joint. So not every patient of arthritis needs a fusion. That's a long story short.
Any other question, Anil?
No, no question.
Shall we move to next speaker?
Thank you very much.
Yeah, thank you, Dr. Pratik Munot. Excellent presentation. Up to the mark.
Thank you. Thank
Thank
you.
you, sir. Now the next speaker is Dr. Nilen Shah. And I request Dr. Sarita Devi, IMA CGP member, to introduce Dr. Nilen Shah. Over to Dr. Sarita Devi.
Dr. Nilen Shah is a consultant orthopedic and joint replacement surgeon at Sir H.N. Reliance Foundation Hospital and Research Center. After completing his MBBS from T.N. Medical College, Mumbai with honors, he did D. Ortho with second rank, followed by MS Ortho Mumbai with a gold medal. He also secured MCH Ortho from University of Liverpool, UK. He then did a knee fellowship at the Avon Orthopedic Center, Bristol, England. He is involved in performing approximately 1,000 knee replacements a year in Mumbai, along with a group of 4 fellow surgeons. He has pioneered the subvastus approach in knee replacement surgeries that is only minimally invasive. He is a reviewer of the Indian Journal of Orthopedics and British Journal of Bone and Joint Surgery. He has held faculty positions in several national and international conferences, including an AIMS update on anthroplasty in 2014. Today, he will be speaking on ensuring satisfaction in knee replacement. Welcome, Dr. Nilen Shah, please.
Thank you. Thank you. Can you hear me?
Yes, sir.
Thank you very much, Dr. Sarita Devi, for those kind words. Now, may I share my screen?
Yes, sir.
Yes, sir.
Can everybody see it?
Yes, sir.
Firstly, I would like to thank the IMA and Sir H.N. Reliance Foundation Hospital for giving me this opportunity. As most of the audience may also know, I have given several talks on IMA, and I'm very thankful for the IMA to give me this opportunity to share my thoughts. Now, I'm going to talk about ensuring satisfaction after a knee replacement. For us to do that, there are 3 simple tasks that are required. We need to choose the correct patient. We need to do the correct surgery. And even if we do these 2 fine, if we are not the correct doctor, the patient may not be happy. So we need to strive to be the correct doctor. Now, choosing the correct patient, it is axiomatic that knee replacement can only treat arthritis of the knee or a badly damaged knee. So the patient must have symptomatic knee arthritis, and X-ray should be confirmatory. When I say symptomatic knee arthritis, on an X-ray, you must see bone on bone. Early cartilage damage is not suitable for a knee replacement. We need to rule out all other extraneous factors, neurological, vascular, hip problems, depression, etc. And I must point out here that a lot of people have underlying spinal problems and they present with knee problems. The success of knee replacement has kind of ensured that most people think that if there is any difficulty in walking around, get your knee replacement done and you'll be happy. But knee replacement can only help somebody who has symptomatic knee arthritis. Otherwise, it cannot help. And we must choose good surgical candidates. We don't want to see patients going into cardiac failure, renal failure, lung problems after surgery. So the patient has to be a good surgical candidate and of an appropriate age. So what we see day in and day out, medial compression test for medial osteoarthritis. So you put the patient's knee in a figure of 4 position, put a little bit of pressure of your palm on the inner side of the knee. You flex and extend the knee and the pain can be seen on the patient's face. If this test is positive and the patient tells you that, yes, this is the pain that I'm getting, rest assured that if you do a good job of knee replacement, these patients are going to be happy after surgery. Similarly, if the patients have lateral joint line pain, then you can do a compression test on the lateral side. And for patellofemoral joint, you can do a grinding test. And most of the pains can be that the patient is complaining of can be reproduced in the examination room. If the patient's symptoms are vague, knee replacement is going to give you a vague result. So avoid those patients. If you are operating on very, very young patients, you need to beware because these may have a higher failure rate and you may need to manage these patients with conservative measures or you may consider an osteotomy. Some people have said that 1 in 3 patients in a multi-center study had residual pain, stiffness, tightness, swelling, and felt that their knee did not meet their expectations. So there is a high level of residual symptoms in young patients. If you are operating on young patients, then the survival rate is also a little less. So ideally, operate on patients at an appropriate age, the ones who've had pain for some time, so that they are grateful after having had the surgery. The current belief is that doing unicompartmental knee replacement, use of modern technology will help in improving the results in younger patients. But I would still point out that this is a belief and we need to choose very, very wisely because an unsatisfied patient is not a happy scenario. Unis can work well in indicated patients. And this is an article which had appeared in Times of India yesterday, where there was this gentleman who was handicapped and he had symptomatic arthritis in one knee, and I wanted to give him a normal knee. So I did a unicompartmental knee replacement for this guy, and he's been very, very happy after that. So in well-indicated patients in monocompartment arthritis, ligaments that are normal, a uni can work really well. Obviously, the patients need to be medically screened. We may involve a physician or cardiologist, but the primary responsibility for the well-being of the patient remains with us. So we have to be choosy onto who we are operating. Even though sometimes the physicians and cardiologists say that he's fit, if it appears that there are issues, then these need to be discussed freely with the patient and the patient's relatives. We need to do the correct surgery. So preoperatively, including the anesthesia and the operative steps. So anesthetist, I would tell you, should be the best that is available under the sun, but who is prepared for the worst. We all have seen anesthetists who are outstanding anesthetists. So what I mean is that the anesthetist should remain in the operation theater. The anesthetist should be time efficient. Spinal, epidural anesthesia, general anesthesia, all can be given, and peripheral nerve blocks can be utilized. And I would point out here that Sir H.N. Reliance Hospital has a fantastic team of anesthetists who remain in the theater, and you are not hunting for them. So they are with the patient from the time the patient comes in, or even before then, and from the time that the patient is wheeled out. My current choice for a unilateral knee is spinal with adductor canal block, and for a bilateral knee is again a spinal with bilateral adductor canal blocks. The adductor canal block, as we have talked earlier, blocks the quadriceps after the femoral nerve has given the motor branches. So there is no weakness, and the recovery of the patient can be dramatic. But what it requires is an ultrasonography in the operation theater. It is not very difficult, but requires some training, and catheter needs to be introduced near the femoral artery in the mid-thigh region, and it blocks the saphenous nerve. We have done several studies which are recognized the world over, because I have got some papers in the Journal of Arthroplasty, which is the most premium journal for the scene of arthroplasty. So here we talked about whether continuous adductor canal block is better than continuous femoral nerve block after total knee arthroplasty, effect on ambulation, early functional recovery and pain control. And what we found out, that the pain control after adductor canal block is similar to femoral nerve block, but patients with adductor canal block have a better functional recovery. We also looked at whether continuous adductor canal block is better than a single shot, and there we have found out that continuous adductor canal block is better than a single shot. We have also done a study currently with H.N. Reliance Hospital, where we have looked at surgeon-administered adductor canal block and USG-guided anesthetist-administered adductor canal block. And what we have found is that the both can be effective, but the ability to keep a catheter in the thigh allows the patient to have better pain relief on the second and the third day as well. Then, friends, I would tell you that we need to do the correct surgery and we need to avoid complications. So we must avoid intra-op catastrophes, fractures, extensor tendon injury, medial collateral injury, vascular and neurological damage. So to avoiding fracture, we should do adequate ligament release, use spacer blocks and not lamina spreaders. We need to be careful with spikes and levers and applying and removing jigs and trials. We need to avoid notching, and there should be no forcible hammering on the knee. We need to be gentle. Most of the patients that we are operating are elderly, and most of us who are doing this surgery are still in the prime of our life and pretty strong. So we need to understand that we have to be operating as if an ophthalmic surgeon is operating. Be gentle. So use spacer blocks rather than lamina spreaders so that we don't damage the bone in any way whatsoever. We need to avoid spikes in the posterior tibia. Get the exposure of the knee by just positioning the knee such that you can get the full exposure without using too many spikes. We need to be very, very careful while inserting and removing jigs and trials. We have to remove them in the same direction, and we have to avoid enlarging any of the fixation holes that are there. We all know that anterior cortical notching can reduce the bony strength and it can cause a periprosthetic fracture. Here there is a small notch in a rheumatoid patient. The patient develops a fracture, so we have to avoid this. So the use of navigation and robotic technology will help us in preventing these sort of problems. We need to avoid reverse notching also. That means you are notching the posterior part of the femur. So we must use high flexion implants, but not at the cost of removing more bone. Preventing patellar tendon injury, we have to identify the knees with risk. Short knees, stiff knees, obese knees, patella baja, previously operated, immunocompromised knees. We have to be very, very careful in doing these sort of cases. Vigilance during exposure is paramount. So make sure that the patella can be retracted laterally before flexing the knee. Remove osteophytes from the trochlea and the patella. These are all surgical tips. Knee flexion intra-op, we have to rotate externally because this markedly decreases the tension at the tendon insertion, and careful posteromedial dissection from the tibia to allow external rotation of the tibia. So avoid catastrophes, the MCL injury, direct injury, saw, sharp retractor, osteotome, Z-plasty, and we still see all these cases coming to us from the clinic where somebody has had a knee injury, but a knee replacement, but there is a medial collateral ligament injury and the patients are miserable. So be careful when you are operating these cases, and be careful who you are sending to when these sort of cases are there that you have to refer. An experienced surgeon makes all the difference between success and failure. So we got to be careful all the time. Removal of osteophytes, medial exposure and release, use of the saw, and we must check MCL integrity. And there is no shortcut to experience. Exposure, osteophyte removal and release, these are all interlinked processes, and one must remove the osteophytes before major ligamentous release. Because when we remove osteophytes, the ligaments get lengthened a little bit, and the amount of release that may be required is lesser. So here you see that the knee has had a full circumferential release from the tibia to align the knee well. I like to do posterior cruciate retaining knees. So I would protect the PCL. I would not excise the medial meniscus as it helps in protecting the MCL. So when we are taking these cuts, again, we got to be careful that we are not damaging any of the ligaments. Here you see that I'm supposed to be cutting in this area. This is the medial collateral ligament. So the spike has to be there just at the right place so that my saw does not damage, and we must use a narrow blade. MCL injury can go unrecognized because the stability and extension is maintained. So unless tested in flexion, it can be missed. So we have to feel it by palpating directly. Vascular injury is also a catastrophe. And although we don't talk about it, it is rare, but 0.2%. So if I'm doing something like 1,000 knees, I would be seeing 2 vascular injuries a year. Fortunately, the rate is even lesser than this because I preserve the PCL and the vessels are behind that. So as long as the PCL is intact, you will very unlikely to damage the vessel, but you've got to be careful in removing the PCL, posterior capsular release, placement of posterior retractors. And at the level of the tibial cut, the area of 11 o'clock to 1 o'clock is particularly relevant. So this is the tibia which is prepared. So this area which I have shown, the vessels are very, very close, and we got to be very careful when we are operating. I have stopped using a tourniquet so that I can protect the vessels even more. And God forbid, if something happens, you can do something about it. So popliteal artery moves away from the tibial surface in 90 degrees of flexion, but still we got to be careful because in 1/4 of the patient that does not happen. So the bone artery distance is 6 to 8 millimeters. It is very, very close. Here also robotics can help because the robo knows where the bone is once you have shown it to them, and then it will not go beyond that. Patient may develop an arterial thrombosis if there is a pre-existing arterial disease. So we have to be very careful with the use of the tourniquet, and we must avoid indirect compression due to forceful retraction or knee dislocation. There could be other complications as well: instability, infection, patellar issues, stiffness, wound healing, and residual pain. The knees that we operate very often are grossly unstable, and it requires experience to decide what needs to be done to stabilize the knee. Greater the instability, the lesser is the amount of bone cut that is required. And if the deformity is correctable, most likely it is because of a bone defect. And if you fill the defect up, the deformity will be correctable. If it is an uncorrectable deformity, it will ligament release. If it is an overcorrectable deformity, that means the knee is very lax, you require to cut less. And if it is a global instability, you may require specialized, what we call stabilized implants. So we must avoid instability by creating equal gaps by the measured resection technique. Distal femoral cut gives you the extension gap. Tibial cut gives you the extension and the flexion gap. Higher the slope, more is the flexion gap. And posterior femur cut only addresses the flexion gap. So this is a little technical thing. We have to establish extension gap and balance, get an equal flexion gap by femoral component, size, position, and rotation. We may use tensioner, lamina spreaders, spacers, sensors, navigation, and now robotics, but we don't really release in flexion. And in measured resection technique, you do a bony cut proportional to the thickness of the component, release as required after trial components in extension or flexion, but both require distal femoral cut and proximal tibial cut perpendicular to their axis. After the cuts have been taken, you can put in a spacer block and move it from extension to flexion, but you should avoid multiple trial reductions. And depending upon how the spacer block behaves, you know whether the knee is tight either medially, laterally, in extension, or in flexion, or in both. And accordingly, you can do a little bit of titration to get a well-balanced knee. I like to preserve the posterior cruciate ligament because I believe it is a flexion check rein, and I would selectively release it to titrate the flexion gap. And there are different shape inserts that are available, which are now a bonus. We have presented our midterm results of cruciate retaining knees in gross deformities, and it is published in the Journal of Bone and Joint Surgery. And what is a balanced knee? 1 to 2 millimeter of opening on either side, 1 to 2 millimeter of forward translation, no backward translation, a touch of hyperextension, no lift off, no squeak, able to insert the trial insert by hand without excessive force. We must avoid malalignment, and by ensuring that the femoral and the tibial cuts are perpendicular to the mechanical axis, we can align the knee well. Difficult for the femoral cut to be exactly cut perpendicular to its mechanical axis because of the femoral bow and the head of the femur is not palpable. In tibia, this is easier because it is subcutaneous. So I see the merit of navigating the distal femoral cut. And again, we have done a study which has been published in the Journal of Arthroplasty, where we only navigated the distal femoral cut, and we found that this is as accurate as full navigation. This study we did in 2014, and this navigating the distal femoral cut, this striker navigation is again available at Sir H.N. Reliance Hospital, and we regularly use it. And even robotics is now available for us to align the joints better. But it needs additional pins in femur and tibia, and it can be combined well with the subvastus approach, and the experience is growing. We need to avoid infection. So do a decanalization of staph, give them chlorhexidine baths, decrease contamination of the wound by being sure that you are irrigating the knee well, decrease the devitalized tissue. I hardly use the electrocautery because I don't want to burn anything. Improve the oxygenation, use antibiotic loaded bone cement, But if you think that there is any doubt, then you need to aspirate the knee early. You need to wash out the knee early. And we may use what is called as a stimulant, which is calcium sulfate antibiotic carrier, where we can put in the knees. So this is a knee with an early knee infection. It should be treated as a make or break case. So incision needs extension. You should send cultures before antibiotics, copious irrigation to salvage the knee. To avoid patella maltracking, as we have talked earlier, subvastus is the key. And I would believe that there should be a reverse thumb test, that it is not possible to subluxate the patella out of the trochlear groove after 30 degrees of flexion. But the surgical approach remains a matter of choice with most surgeons. Personally, I use subvastus for all, and I would also use a lateral subvastus in indicated patients. People have said that 1 in 3 patients, if you take patellofemoral views, have some degree of tilt. So this is what I mean, that these patients have some degree of tilt of the patella, what you are seeing on the left side, and what you are seeing here, perfectly aligned patellofemoral joint after the subvastus approach. Now, many other people have also claimed that the subvastus approach is good, and some other surgeons are also singing its praises because it never has a delayed tilt, and it is a universal approach for all knee deformities. But some people do find it still difficult. So I have probably used it now more than 13,000 times. And here I will just show you a arthroplasty example. This is a lady who had a gradually increasing soft tissue swelling and anterior and posterior villonodular synovitis. So this is a non-tourniquet subvastus approach, and you can see the approach. The whole quadriceps muscle is being retracted. I'm releasing the vastus medialis obliquus attachment from here. Here, whatever you are seeing is the anterior PVNS. So here I have removed it. This is the exposure of the lateral gutter. This is the exposure of the suprapatellar area. This is the lateral side. This is the medial side. And this is the whole knee, which is seen after a well-executed subvastus approach. And when you get to close it, just a few stitches here and the whole knee closes in its anatomical position. So this is my personal observation. I have used it in obese, in valgus, in stiff knees, in revisions, and published on all these things. We should be conserving blood, and not using a tourniquet is an advantage. And we have published about strategies how to reduce blood loss in patients who undergo knee replacement. And again, we have a publication in the Journal of Arthroplasty, whether we can combine systemic and topical tranexamic acid. Can it be a better regime and yet safe? And now further research of this, we have given a paper for publication, whereas oral tranexamic acid can also be given for a period of 3 days to reduce the blood loss even further. Even this paper has been accepted. So at present, unilateral total knee is almost never transfused if the pre-op hemoglobin is around 10. Bilateral is transfused if the pre-op hemoglobin is less than 12, around 50% of the times. The closure needs to be watertight. Use a round body needle. You need to be gentle with tissues, irrigate. The facial closure, even for the subcutaneous tissues, is important, and continuous 3O for skin, so that the knee can be mobilized straight away without worrying about any soakage or anything. So do the correct surgery, get a well-balanced, well-aligned, stable knee with excellent patellar tracking, good range of movement, cement it well so that it is durable. You may use measured resection. You may use navigation, robotics. I like CR knees. I like to do subvastus knees, tourniquet less. Use adductor canal blocks and use cement such so that the knee is durable. If the knee is not doing well, think of infection. Once ruled out, give time and listen to the patient. Patient interactions are extremely important. So arrange patient-friendly events where you are seen as a person and not just as a medical doctor, because finally we are from the same community. And I regularly arrange garbas and walkathons for the patient. Currently, I have not been able to arrange because of the COVID situation, but once it eases, I will arrange them again. So we have to be the correct doctor and think from the patient's point of view. We all are empathetic, but we must have genuine care that shows, and also think of cost. If we are offering such treatments which are not affordable to most patients, then there is something wrong, because we have to be affordable also to our patients so that they can take maximum benefit. Now I would introduce this concept, which is a net promoter score. That means if somebody utilizes your service, be it a knee replacement or a bypass surgery or even a consultation, how many people would actively promote you and how many people would say that they have not been happy? So a net promoter score is a score where if 100 people have taken your treatment, how many are actively promoting minus how many people are detracting your service. It does not include passives. It does not include those people who say, "Okay, we have taken his treatment, but we are neither happy nor unhappy." And the industry considers a score of 30 as very, very good. So we put questions to our knee replacement patient at 1 year, and we did this when there was this lockdown because we were just sitting and twiddling our thumbs. We didn't have anything to do. We all have records for all the patients plus their phone numbers. So we put a question to all the patients that were operated a year earlier when the lockdown started. Just 2 questions. Are you satisfied? And will you recommend this doctor to others? So we did this 1 year satisfaction study post total knee replacement. 860 patients, 95% of the patients were satisfied with a net promoter score of 96%. So the aim is to go from patient satisfaction to patient delight. I thank you for your attention.
Thank you, Dr. Nilen. It was a very wonderful presentation. Any question now?
Very kind, Dr. Nilen has got such a high score. Quality of this for the satisfaction of patients. The wonderful score, Dr. Nilen.
I think there is a question on the chat box. May I answer that?
Yeah.
There is an anonymous attendee. How much is it avoidable to do knee replacement in patients more than 80 years old who are otherwise physically fit, particularly women? So I would say that we operate on a patient who is above 80 at least once in 3 days, and they do very well if they are otherwise surgically fit. Although most of them will be osteoporotic, we need to be careful as to how to handle the bone and what implants to use. In fact, I have operated even on a 100-year-old lady for a knee replacement who was so happy after that 6 months later, she got the other knee done when she was 101 years of age. So 80 is not really a problem, and it will be easier to satisfy an 80-year-old than a 45-year-old. Now, Dr. Nimesh has asked, what is the reason for not satisfaction? This is also a very, very important thing. And there we have found that as a surgeon, when you are providing a service, it is not just your surgery. It is the hospital experience, the behavior of the junior doctors, behavior of the nurses, the overall cost of the patient, the availability of the doctor post-surgery, how he responds and talks to you after the surgery, and if there is any residual pain. So of all these factors, the patients with residual pain were very, very minor. And now with robotics and navigation and all that coming in, I personally believe that if you hike up the patient's expectations too much, then satisfying them will be even more difficult. So realistic expectations of the patient are also very, very important. I tell them that for them to be really comfortable post-knee replacements, total recovery is 3 months to a year. So I tell them on day one that this is what it is going to take.
Any question from the panelist? Dr. Jitesh?
So I think that you explained very well.
Yeah. Now, shall we move to next speaker?
So remember the net promoter score.
Yeah, thank you so much, Dr. Nilen.
Thank you. Thank you, Ushaben.
Yeah.
Thank you. I take your leave. Thank you very much.
Yeah, thank you so much. Now, the next speaker is Dr. Prashant Kamble. I request Assistant Secretary, IMA CGP Mumbai Sub-Faculty, Dr. Kajal Ahuja, to introduce the speaker.
Dr. Prashant Kamble is consultant hand, wrist and elbow surgeon at Sir H.N. Reliance Foundation Hospital and Research Center. He was assistant professor at St. G.S. Medical College and KM Hospital, Parel, Mumbai in 2014. He did his clinical fellowship in hand surgery from Germany in 2014, clinical fellowship in hand surgery and wrist arthroscopy from Hong Kong in 2015. He also did fellowship in hand surgery, wrist and elbow arthroscopy from Germany in 2018. Today, he'll be speaking on wrist pain, common causes and treatment. I welcome Dr. Prashant Kamble.
Thank you, madam. Good morning, everyone. And thank you for your kind introduction. Can I share my screen now? Okay. So is my screen visible?
Yes, sir. Yeah, yeah.
Yeah, okay. So good morning all, and I would like to thank you IMA Mumbai branch and Sir H.N. Reliance Hospital for giving me this opportunity. And I will be talking on the wrist pain, the most commonly underdiagnosed and under treatment as well, as we move from the knee and other joints that we have seen since the morning. So what are the common causes of wrist pain? Because as we all know that wrist is the most complex joint in the body. Okay, it has more bones, more ligaments, and very, very small ligaments, and difficult to at a time diagnose the source of pain. At a time, it becomes difficult to treat as well. So as an approach for any pain management or any source of pain or any approach to any joint affection, so we do the same modalities here. That is what we do, like look, feel, move, do some test and do lignocaine injection to locate the source of pain. So what is look? It is basically the inspection. So you should see from where the pain is coming, which side of the pain is coming. And the most commonly, as I said, unless the patient function is affected, patient won't come to you, because the wrist pain commonly they are treated at home with some home remedies or an inappropriate treatment. Sometimes it goes, and unless the patient is affected, patient doesn't see you. So when patient comes, you must approach in a systemic manner, like that is inspection. You feel the joint, move the joint, check for the range of motion, compare that on opposite side, how the joint is moving. Is it painful? Is it the range of motion, the grip strength, the most commonly the grip strength, whether it is affected, or if you are in a doubt that patient, the pain is coming from multiple source. If your diagnosis makes sure that it is coming from multiple source, so you can inject lignocaine to mask that pain arising from supposedly point A, and if the pain is coming from point B, the patient will continue to have pain despite of the injection. So thumb tip is your friend. Okay, so when you start examination of the wrist, you must use your thumb tip. Okay, as like you are unlocking your phone, so you can palpate the wrist joint with tip of your thumb. So you can palpate very easily those small bone, and you can come to some conclusion that the source where it is coming from. Now, in order to understand, for our understand, we divide the wrist pain into two parts. The pain arising from the radial side, that is include your thumb, index finger, and the center of the middle finger, and the pain arising from the rest of the part, that is the ulnar sided. So what are the anatomical structures? So you must know the anatomical structures that are around the wrist. So then it becomes very easy for you to diagnose and treat the pathology. So what can be the source of pain? That also we divide into two parts: the pain arising from the joints and the pain which is arising out of the joints, which is not related to the joint. So what that is intra-articular, that is pain from the joint on ulnar side. So the structures, what are coming in a way as you go closer to the joint is your skin and subcutaneous tissue. Below the skin, there will be a tendon. So two-side tendon, one from the flexor side, another from the extensor side. So out of this, the extensor carpi ulnaris, the tendon which causes the wrist extension and ulnar deviation, that is ECU, extensor carpi ulnaris, is one of the extra-articular common cause of pain. The inflammation of the tenosynovium or the inflammation of tendon itself can cause a very commonly encountered ulnar sided wrist pain. So on volar side, similarly, we have the ulnar nerve on the ulnar side. So that also causes a pain that like something like a compression of the ulnar nerve, that will give you the pain and the tingling sensation in the ulnar nerve distribution. Another uncommon symptom, not that common, is the pain arising out of the ulnar artery. Most of the time it is the AV malformation, or it is the some of the intraosseous tumor arising, or sometimes the ganglion arising, they are compressing the ulnar artery, or sometimes the peripheral vascular disease that causes the compression of the ulnar artery and can give rise to the ischemic symptoms. So look for the tender spot. As I said, in a systemic way, suppose patient is having the ulnar sided pain, then you can start from the radial side. The reason why, because once the patient is comfortable, relax, he or she will allow you to examine patient in a very smooth manner. So if the patient is having ulnar side pain, then you start from the radial side. Now this patient has the opposite. He has radial side pain arising at the base of the thumb, where the thumb base articulates with the scaphoid joint. And when I ask patient, where is the pain located? As you can see in the picture, it is exactly pointing out from where the pain is coming. As you have seen that I have started from the ulnar side and then I have reached to the radial side. Now look at there, where it is pointing. It is the base of the thumb. So what are the structures at the base of the thumb? It is the first carpometacarpal joint and the scaphoid. So I can make some differential in my mind that it could be arthritis at the base of the thumb, or it could be something related to the scaphoid. So I did order the X-ray, and it, as you can see very, very clearly, there is a evidence of a scaphoid fracture which underwent into the non-union. As history, he was having trauma for 3 months back, for which he didn't took any treatment, but for the X-ray, as you can see clearly, there is a non-union of the scaphoid, the fracture which was not united. So this is a systematic approach for the wrist pain. So any pain, radial side or ulnar side, start from the opposite side. Make comfortable patient, allow patient to be relaxed so that he can participate in a smooth examination. So another, the intra-articular side. Now we go to the ulnar side. What is there? So carpal bone and the TFCC. TFCC is a black box of the wrist. Okay, if the patient 90% of the time it is the pain which is arising in the wrist, it is from the triangular fibrocartilage complex. Because of the injuries of TFCC, the 90% of the ulnar sided wrist pain are from the TFCC injuries. Okay, so what is the function of TFCC? It is somewhere here located. It holds the distal part of radius and ulnar together. It stabilizes the ulnar and carpal joint, and it allows a wrist to have a smooth range of motion. So ulnar sided pain, 90% of the time it is the triangular fibrocartilage complex injury. So let's have some clinical examination. So this patient had a history of twisting injury, and 2 weeks back, and he came to the outpatient, showing that you can see in the video. So he's saying that I'm having pain in this area, and whenever he makes flexion and extension at the wrist, basically he wants to grip, that causes the pain. Another thing, whenever he wants to press anything on the table, the pain aggravates. That is again very classical signs of the TFCC injury. So what you examine, put wrist into the dorsiflexion and ulnar deviation, stabilize the elbow. As you can see here, the elbow is stabilized. I'm stabilizing this proximal part of the forearm, and with my right hand, I'm putting wrist into the dorsiflexion and the ulnar deviation. And I'm asking, just point out, just look at the patient face. See how much pain he's getting, and he's saying, yes, I'm getting that pain. Yes, that part is not good for me. Okay. So this is a pain aggravating on radial deviation and wrist dorsiflexion. Another very common test is a ballotment. Now look here, what I'm doing. I'm just moving the ulna with compared to the radius. See how much it is ballotable. So it is moving in forward and backward direction. Compare that on the opposite side. So you can see that how much it is ballotable. So that again, very classical of the ballotment test, and indirectly indicating the massive tear of the triangular fibrocartilage complex. So that warrants a treatment. So we advise the investigation, and that was suggesting of the MRI. MRI is the one of the non-invasive test that you can order in case if you are suspecting the TFCC injury, and it's suggestive of the TFCC tear, complete tear. It is completely avulsed from the ulnar sided attachment. Okay, so if you want an invasive investigation, that is wrist arthroscopy. That is a gold standard investigation to diagnose the TFCC or ulnar sided wrist pain injury, but it is invasive. So what is the treatment? As newer modalities of treatment, we do treat these with the wrist arthroscopy. As you can see, these are the very small finger straps. These are holding your fingers, and this is a unit traction tower which is holding the wrist and elbow, so that we can place a small arthroscope. The arthroscope size is very small, 1.9 mm, very delicate, but very helpful to diagnose the wrist pathology. So we treated this patient with the wrist arthroscopy, and you can see those small holes. Can you see those small portals from which we treated the patient? These are the small cuts, not even suturable. We didn't suture even post-operative, that I will show. But once you've done your surgery from here, you can repair back the TFCC from where it has torn. And the best part, this surgery I have done under a local anesthesia. As you can see, the patient is moving the finger. See the amount of incision that I have taken. It's less than, less than 2 to 3 millimeter also here, and just that's 3 incision. That's a very keyhole surgery. And you can treat this patient as a day care under portal specific local anesthesia. Okay. So very important again, sutureless surgery, you can say. So with these are the sterile strips for which you can close the wound and you don't have to even suture the wound. Okay. So this is how we treat the TFCC injury. And this is the image you can see once the sutures are healed. It's barely visible, that surgery, and not even here you can, it is difficult to see where that the scar is gone. Even here also very difficult to note. So that is the beauty of the doing the under arthroscopic surgery, although technically demanding, but yes, very much rewarding, and it's very minimally invasive as well. Now moving from ulnar side to the radial side, as we are doing the arthritis day. So the CMC joint, first CMC joint, that is carpo-metacarpal joint, where the thumb base articulates with the trapezium. Okay, that is the very, very common site for arthritis in the wrist. Okay, most of the middle-aged female and around above the 45 and above the 60, those who are coming with the radial side thumb pain, unless and prove it is the first CMC joint arthritis. Now this is a young patient who had an injury almost 2 years back, which was treated with the plaster for his thumb base fracture. Now after 2 years, he complaining of the pain on his radial side. Okay, so what is examination? So when I do see amount of pain he is getting, the moment I push thumb down, that is called a hyperextension, and he is getting severe pain. He's saying, just stop it, I'm not comfortable, so I have to stop it. So I did investigation for him, the x-ray. Can you see now what here is the joint? The base of the thumb is completely arthritic. There is no joint space here. This is the thumb base, this is the trapezium, and that has completely landed into the post-traumatic arthritis. Okay, so this is a post-traumatic arthritis for this patient. Now, the degenerative, as I said, any patient, female patient above the 45 who is coming with the radial side thumb base pain. So if you can see, if you can observe rather carefully the base of the thumb, can you see something? See here, that patient, we did the x-ray, also it's showing the degenerative arthritis. And very importantly, on clinical examination, there is a shoulder sign. See, there is a subluxation of the base of the thumb. If you compare that on the right side, see here with the arrow, can you see that the thumb is completely normal on the right side and left side is subluxated. So it's like a shoulder, it's loss of contour of the shoulder on the left side. So this one, you just ask patient to do this, you will come to know this thumb base is subluxated and it is landed into the arthritis. So what is the treatment? Unlike the other arthritic joint like knee or hip or elbow for a shoulder, we don't have any implants here, as if now, at least in India, we don't have the implants like we put in the knee or hip. But the treatment is again very simple for this type of arthritis. You just remove the trapezium and whatever space available, you can fill that space with some tendon interposition. And once you see the clinically the thumb is subluxated, you need to reconstruct the ligament. The treatment is trapezium excision and the reconstruction of the ligament, that is in a short form LRTI, ligament reconstruction and tendon interposition. Moving to another source of pain, very, very common again in case of such as rheumatoid arthritis, where the all the joints are involved. You will also see the rheumatoid hand and inflammation and all the signs of pansynovitis, all you will see with the in the hand as well, hand and wrist as well. So few terminologies that one must know about this: tenovaginitis, tenosynovitis, tendinosis, and tendinitis. Tenosynovitis is the inflammation of the tendon. Tenovaginitis is the inflammation of the within which tendon is contained. Tendinitis is the inflammation of tendon itself. Tendinosis is the degenerative process of a tendon. So again, nowadays, what I have seen on the radial side pain, okay, most of these patients are teenagers to the middle-aged female who are, or the other patient who are continuously using their cell phone. This in recent past, I have noticed this, these kind of pain are coming very high number as just, and when I ask them, they have either recently purchased a new phone, which is they are continuously using for last 3-4 months, or something related which involves a more use of your thumb. That could be a professional related, like a barber who has to use the thumb continuously, or sometime the desk job worker where he or she has to use his or her thumb very continuously. So these patients will complain of the pain at the radial styloid, exactly not the base, but just a little bit proximal to it. And when you move the thumb inside the hand, that is like a flexion of the thumb, the pain aggravates. As you can see in this patient also, patient is complaining the radial styloid pain. And when I move the thumb, you can see that pain is aggravating. So this is a tenosynovitis of the first extensor compartment of the wrist. That is the two tendons, abductor pollicis longus and extensor pollicis brevis is affected. So, so what is the treatment? So initial part, as I said, you have to treat what it is causing, avoid excess use of thumb, put them into the splint, use sometime steroid injection. Those patients are not responding to the non-steroidal anti-inflammatory, the NSAIDs, analgesics treatment, non-compliant with the splint, go for the local steroid. Either you can give blindly or you can give under the guidance of ultrasound. I would strongly suggest go ahead and give the injection ultrasound guided, because it is 100% target oriented, which will deliver exactly site of the lesion. But what if both the treatment fails? Like, patient is non-compliant, although the compliant not happening means pain is not going, injected steroid not working. So what is the next option? That is the surgery. So you have to counsel about the surgery, where we release, again, take care surgery, where we just release the sheath within which these two tendons are contained. And immediately post-surgery, patient will definitely have the good pain relief. The only part you have to take care of the superficial branch of the radial nerve, that one should not damage during the surgery. Otherwise, the patient will never get relief from the pain. Otherwise, if you take care, surgery is very much rewarding on day one itself. So another tenosynovitis, which process the wrist, is the infection of the tendon itself. That is a 4 cardinal signs of the cannibal: flex attitude of the finger, fusiform swelling, tenderness along the sheath, and painful passive extension of the affected digit. As these tendons are crossing across the joint, so it can be present at the wrist level, or it can be present at the terminal part, that is at level of A2 or A for pulley. Treatment, surgical intervention, no doubt you have to drain those abscess or whatever's content there. you have to do the debridement, and surgical intervention is needed in all this. So very common another thing, the tenovaginitis or the trigger finger. Just patient will come and tell you the diagnosis. You don't have to diagnose here. Can you see that click or that cut extension lock? So treatment is again straightforward. Just release the A1 pulley, non-surgically sometime indicated, but avoid injecting steroid. Most of the time these patients need the surgical intervention. Coming to the last part, very important and very common. Okay, carpal tunnel syndrome, compression of the median nerve at the level of wrist. Patient will have tingling sensation in the thumb, index, and some part of the middle finger. So what is the test? Phalanx test. You just have to flex the wrist and ask the patient whether he or she is getting tingling. Or another test is Durkins, means like you compress the carpal tunnel, or something like what you're doing to feel the radial pulse, putting 3 fingers on the radial artery. Instead of that, you place your 3 fingers on the carpal tunnel and just compress it for a few seconds. Patient will have the tingling sensation. Or combine both these tests together, and like compression as well as deflection. That is what I do, and which is a 100% sensitive and 100% specific. Just see the video. Now I have done both flexion and the compression at the carpal tunnel. And moment patient is saying, yes, I'm getting the tingling here. So he's pointing where he is getting tingling. So that confirms the diagnosis. And investigation advice is electrodiagnostic studies, EMG and CVs, that will give you the amount of compression. And the treatment, usually pregabalin is advisable at night with the warning some patient may get some giddiness in the early morning, and the night splint to avoid the flexion at the night. So try this for 6 to 8 weeks, see how the things are going. If it is responding, then you don't have to worry, things will settle down. But if the things are not settling, tingling sensation is increasing, patient is getting night for sleep disturbance because of the tingling, yes, then the surgery is indicated. And what we do is just to release the carpal tunnel, and patient will definitely have the good outcome if you release adequately. And these are again daycare surgery, where you can do definitely under local anesthesia or general anesthesia, depending on the patient requirement or anesthetist advice. But yes, surgery is again very rewarding. Patient feel immediate relief after the surgery. Okay, so moving from lockdown to unlock, hoping to see you all in some meeting with the physical presence. Thank you. Any questions? Happy to answer them.
There are no questions in the question answer box.
So I see there is one question in Q&A chat. Can be ganglion treated by any drugs, or for all ganglion needs surgery? Okay.
Yeah.
So definitely for ganglion, medication will not work for the root cause. Of course, if the ganglion is painful, you can give the analgesics, but that won't be the treatment for the root cause. You need to find out from where it is coming. Okay, if it is from the tendon sheath, or whether it is coming deep inside the carpal bone, that first you have to diagnose, and then you have to ask whether patient want this surgery as a cosmetically. Most of the patient are the pre-marriage. I have seen many of the patients, they come in the pre-marriage, especially the females. They say, I have this swelling since many years, but I don't have any problem. but I just want to take this out as my marriage is near date. That is the most common and the most common indication for they come for that in for the treatment only. So the treatment, again, unless it is painful, it is increasing in size with the shorter span, then only I advise the surgery. Otherwise, surgery for the ganglion not is advisable. Here is the only case where patient has to decide and patient should ask for the surgery. Okay, you don't have to tell unless it is painful, swelling which is increasing rapidly. In that case, yes, definitely you have to advise the surgery with the warning that it may come back. Okay, that you have to clear patient before surgery.
So there's one more question.
Yeah.
Wrist pain due to RSI is very common these days due to excessive use of laptops in work from home. How do we manage this problem?
Correct. So again, some modalities like, in recent past, what I have seen, the patient who are coming with the wrist pain, they are continuously, this would be the position of the laptop. So what I'm advising them, use a soft padding here at the level of wrist here, somewhere here, so that they can keep that on the place where they are working. So that will avoid one pressure point. Means if you're continuously at this point, just moving your laptop or scrolling your mouse, that will cause a contact pressure at a single point and will make you more discomfortable rather than the pain. Okay, and that will sometime cause the compression of the carpal tunnel and will land up into the transient carpal tunnel syndrome. But what I advise them is a very soft padding, which is available there in the shops, which you can take the help, where you can keep it here, you can keep it here also. So if you keep it here, that this much part remains in the air. So there will be no pressure point here. As you have a lot of muscle here, there won't be any pain or any discomfort using that. So this is what I advise, and they are very, very happy about this, the change of the position, adding the soft padding just below the distal part of their forearm.
So does the size of the mouse matters?
No, it is up to their comfort, what size, what they are using, and where they are keeping. That is rather more important, where they are keeping, if it is at the edge of the table where this part, it remains in the air, then it is okay. But if this part is compressing, means if it is mouse is somewhere here and your the pressure point, again, if it is come in contact, that will aggravate the pressure. But if this part remains in the air, it won't cause any discomfort. For size, no, it is up to their personal choice, what they are comfortable with.
Sir, exercise physiotherapy can help
for
this carpal tunnel syndrome?
Exercise per se, there are no particular exercise. What we have to do is, if you ask them, they have only two things. The patient, especially the female patient, homemaker, they have, squeezing the cloth or making roti, chapati. So basically, it is the wrist flexion that aggravate the carpal tunnel pressure and causes the pain. So you have to avoid this patient, this position, the flexion of the wrist, that you have to avoid. Okay, so that's why we advise them a splint, night splint, because most of the time they have more tingling in the night, so we avoid them. So exercise is no particular exercise, but yes, you have to avoid this particular moment where it aggravates the carpal tunnel pressure and causes the increase in the symptoms.
More question, Anil?
So I think you've taken this question.
Another question I can see is tendinogenitis is more common in diabetic patient. I would say it is more common in the thyroid patients. Okay, thyroid patient, as you can see, the pulleys through which the tendons are gliding smoothly. The intra substance, the matrix, the substance get deposited, and that causes the gliding difficult. It is the pulleys, they're like a ring, and when you pass it is through it, it should be a smooth gliding. If the thyroid causes that occlusion of that pulley system, and that becomes difficult to glide, that's why they get the trigger cut. That is what you commonly come and say to you, my finger is getting cut. This is what the term most of the time they use.
Thank you, Dr. Prashant Jamre, for giving excellent, wonderful presentation. Now we'll move to next speaker, Dr. Vaibhav Bagaria. I request Dakshini Kashyap, an IMA CGP member, to introduce the speaker. Over to Dr. Dakshini Kashyap.
Good morning, friends. Dr. Vaibhav Bagaria is the Director of the Department of Orthopedics and Senior Consultant Joint Replacement and Sports Injury Surgeon at Sir H.N. Reliance Foundation Hospital, Mumbai. He completed his MBBS from GMC Nagpur and MS in Orthopedics from KEM Hospital, during which period he received 3 gold medals. He then pursued orthopedic fellowship at Medical College of Wisconsin, USA for a year. During that fellowship, he received 2 international awards and also diploma from CCOT, Belgium. He then underwent fellowship in advanced joint replacement and adult reconstruction in Germany, and later at Perth, Adelaide, and Melbourne in Australia. He is the first Indian to top the International Diploma CCOT exam. He has special training in hip and knee revision procedures, hip resurfacing, and unicondylar knee replacements. He is well versed with the latest technology in the field, especially minimally invasive surgery, computer navigated surgery, and patient specific instrumentation. He is a member of the editorial board of many journals. He has published several peer-reviewed publications in national and international journals and has written several books and book chapters. He has received several national and international awards throughout his illustrious academic career. He was selected to represent the medical community in the Beijing Olympic torch relay held in 2008. Today, he will be speaking on robotic knee replacement, a paradigm shift.
So thank you, Dr. Dakshini, for that introduction. Are my slides visible to everyone?
No, sir. You're not shared.
Is it now visible?
Yes, yes.
Yes.
Okay. Thank you, Dr. Dakshini, for such kind introduction. And thank you, the entire team IMA, for inviting me here. It's always a pleasure to talk to such elite audiences. So my talk is on something different today, and it's just not another academic talk on the occasion of this World Arthritis Day. I'm a surgeon and I'm also a technology enthusiast, so you can expect some bias when I speak about the technology. But what I'm going to talk today is not just about technology, because technology by itself is not sufficient. We have to combine good technique and teamwork to ensure that we get the most or the best out of technology. And this talk will have lessons and insight for all specialties and possibly for all facets of our life. We all know that the paradigm shift is already happening, and we can all see that there are technology which are changing all the aspects of our life. We have got driverless cars, we have got drone-driven helicopters, we have talked about quantum computing, and we can also see how the 3D printing and 3D technologies have transformed the way we plan and execute surgeries. It's no more science fiction, it's all there, it's all for us to kind of embrace and see where we are headed. But certainly we all are also aware that there is need for improvement on healthcare. And when we talk specifically about patient satisfaction about after total knee replacement, it is related to many different things, and particularly for high demand active patient there is definitely a scope of improvement for all of us. We also know that the total knee arthroplasties are failing, and most knee revisions were due to instability or malalignment, and better alignment and improved outcome may result in less wear and better implant survivorship. We have also known, and all the research have pointed out, that the knee implant may last longer when they are accurately aligned. And that's where the robotic technology comes into play. And we'll see that the earlier robotic things were just the balancing instruments. Then we moved on to navigation tool. The early robotics were surgical guide, which executed the surgery with accuracy. And today we are talking about handheld robotics, about which we'll see more. So the robotic instrument or the robotic arm that we have at Sir H.N. Reliance Foundation Hospital is this. This is called a SCORI. It's a product by Smith & Nephew. And that on your left hand side is the console for this robotic thing. And there's a small instrumentation tray in which all the instruments are kept. And at the centerpiece of all this is this robotic arm, which is called as the Cori handheld sculptor. So this is how the entire robotic looks like. There are different steps. There are a lot of technicalities in this, but since this talk is for our IMA people, I'll be just giving a brief overview on what we do in robotics. So we set up, we register the patients, then we plan for an implant, we go for the bone cuts, validate that cut, do our trial implantation, revalidate that, and then cement the final component and followed by the closure. So these are the surgical steps when we do a robotic knee replacement. The key are 4 things, and these are also the highlight of these new things. So first is the image-free registration. So there are different robotic platform available. In some, the CT scan is required to get a patient data. So what is done is that the robot creates an image of a patient's knee using software. It can be done in 2 ways. One is using the image like CT scans, X-rays and certain markers, or it can be done image-free in the real time. So here you will see that we are using a probe to map out the patient's anatomy. So that's the first step for any robotic thing. The second step is the heart of the robotic technology, which is the patient-specific planning. We all know that we are all different people. None of us are same. And that's where the robotic and the technology really help. So, and we'll listen about it more when we go to the next slide, and you'll see it in real time how we do it. But this is the heart of the whole thing. So for every patient, certain patients are loose, certain patients are tight, the alignments are different. And in this screen, it gives the surgeon an ability to kind of work around what's happening. Whether we need to keep a knee loose, lax, how do we align, whether we want to give it slight varus or valgus, that's where the whole brain lies. Then the third step is execution of this. This is the exact picture where you will see that all the pink area is what the robot has determined to be removed. So this robotic arm only would cut at the area which is defined by the computer. The moment it steps out, it will stop. And that's how these ensure the accuracy. It will cut to the right depth, it will cut at the right inclination, it will cut at the right slope. So in all the 3 planes, the system is aligned, and the moment the robotic arm steps out of it, it will stop. So that's where the robotic technology comes. And finally, of course, it also allows us to check whether what we have done is correct or not. And all this happens in real time, and that's the advantage of a robotic. I will run through the animation of how it is done. So you will see the console is there. This is the console in which we plug all our things. This is the eyes of the robot or the infrared cameras. And this is a screen that we can use to kind of ensure that we are planning. We put 2 markers here on the tibia and the femur, and these are the trackers. We then just move it around to see whether the camera can see that or not. These are the checkpoints that are put. So every 8 minutes we check whether we are at the correct thing or not. So whether the robot is oriented in time and place is done through these checkpoints. Once the checkpoint is there, certain input of data is made so that the computer knows or the robot knows how we are aligned. So these include the ankle, the knee center, the femur center, and the center of the hip. So by doing all the, it orients itself. Then it collects how the native anatomy is there. This is the neutral range of movement, and this whole thing it collects. And then you will see that we are mapping out the whole surface. So we are creating, by painting it, we are creating with the software what's happening. So this is the tibial side, and we are kind of doing this. And you will see that the entire anatomy of the patient's femur and tibia is created. This is the planning screen, and surgeon can then increase or decrease, shift the size where it wants to position the implant. Once that's done, one checks the gap before the surgery, that how the knee is aligned. And it's an important part, because not only the alignment but balancing the knee is also important. So you go back to the screen and aligns it. And once that's done, the amount of bone to be removed is checked. And again, as I said, every 8 minutes the checkpoints are taken, and this is the area of the bone that needs to be removed. And this is how the robotic arm is functioning, by accurately removing the bone in the well-defined area where we had planned. So it will exactly cut it according to where we had planned. This is on the tibial side. The robotic arm is working to precisely remove the amount of tibia that needs to be done. So all
Dr. Anil sir?
Yes.
I guess Dr. Vaibhav sir has lost the connection.
Chirag is there?
Yes, ma'am, I'm here.
Yeah.
Dr. Bagaria is joining again, I guess.
Okay.
He lost connection.
No, sir. Yeah, he's rejoining. Some problem.
So sorry about that glitch, but that's the thing with the technology. and I'll come to it at the end. And I'm sure at the very end, you'll appreciate what I said and what we just witnessed about the technology. So it's important to keep your cool when you're using technology. And the technology has its own shortcoming, just like we just now saw. And trust me, it was not intentional to prove a point. But yes, technology does have its own limitation. So the first step is the setting up the operation, where we expose the knee, we do a limited relief, remove the osteophyte, put the checking points, insert threaded pins in tibia and femur, connect array, and ensure the visibility in all planes. So this is a short video of how we are doing this. You will see. So these are auditory simulations. So that's me. I'm mapping the tibia in the manner we just showed. So the computer will recreate the patient's anatomy based on what we did just now. So again, that's the femur, and then we came to tibia, and you'll see all these array which is there. So it's very important to get these auditory feedbacks. So computer is telling that it is mapping it in the right direction. And you see that this is how I'm mapping. This is a real scene of the surgery that we did yesterday. So you'll see that I'm creating the tibia here. Yeah. So the next step. So the next step is the planning stage. The next step is the implant planning stage, where you will see that the amount of the cuts, the valgus varus, the rotation is all done here, and you can see that this is the gap that we have found. So these are on both the screens. You can see that how we'll be planning this whole surgery. The third, as I said, is how we remove the bone right now, and in this video you'll see that I'm removing the bone. So this is the robotic arm working on it. I've just phased at the bone, and it is moving and cutting the bones on the very well defined trajectory. So just as I said, so we are just holding the thing, and the robotic arm is doing. Some people say that this is not true robot, but I feel more comfortable in holding the robotic arm in my hand, because in case anything goes wrong, I'm there to control it. And you can see it in live, real time. That is how the bone is being removed. And then this target marker shows me where I have to make the peg holes. You can see it's like playing a video game. You have to accurately mark where you are going for your jigs to place. Once that's done, we do what is called a scanning and validation. So you'll see we have put there, and we are just seeing how much degree of varus valgus is achieved after putting the trial implant. And then we can fine tune our surgery based on this. You can see, so that is the range that we have done. So there is 6 degree rotation. There is still some varus left. So the computer will correct it, and we will see that over time it is changing. So this is how we validate our cut. And I'll run through these case examples that we did in this week. So you'll see that there is a complex valgus knee here. She was a 60-year-old lady which had a valgus deformity, difficulty in doing things. It's important to take a scanogram and AP and lateral X-ray to be able to plan accurately. So this is a complex deformity which otherwise would have been a complex case. You'll see how we have planned. We have kept the alignment at 0. This is how the computer tells us this is the planning stage. Here, this is again a technical aspect. If you look at any knee, so the overlap suggests the tightness. So any valgus knee will be very tight in the lateral side, and the green thing is showing amount of the tension on the medial side, whereas the purple thing, the orange thing is showing the opening on the medial side, whereas the purple thing is showing the tightness. And you'll see anything below the graph means that the knee is tight on the lateral aspect. So this is how the native knee of that patient was, very tight on the outer aspect because it is a valgus knee. And you will see how if you had not done any balancing, the component would have been. You will see it is tilted to one side. This is how the native is there. But once we have done all our releases and balancing, you will see both the purple and the orange are same. That means the tension on both the sides are the same. So this is how the computer helps align the knee. And this is clearly reflected on the X-ray, where you see that we have achieved a very good alignment both in the frontal as well as in the coronal and sagittal plane. So all three planes are aligned. To the native eye, this may seem a bit this, but when we use computer, it clearly tells us what is the degree of deformity. Another case example here, it's a straightforward varus knee where both the sides are varus. This is the planning stage. Again, as I said, that the pre-op alignment is there. The degree of cuts, you'll see that on one side it is cutting 2.5. Computer is recommending on the other side it is 9 millimeter. Similarly, on the femur side, 6 and 9.5. On a different plane, it is suggesting 10.5 and 10. So all this the computer has planned. At the same time, it gives us an opportunity to override it at certain point. With time, the man and machine integrate itself, and that's where the future lies. That we sometimes override based on our judgment, but at the same time, the computer tells us what needs to be done. This is a different plane in which the computer has told us how much is the bone defect, where we want to place our implant, and this is more like a CT scan and implant positioning on a CT scan. So you will see again the fact that it is a varus knee. There is tightness on the medial side. You will see the degree of overlap, which is the orange one, is much more on the medial side. So medial side is very tight, the lateral side is tight but not that tight. So this is how it assesses the gap for any varus knee. And then this is how I gave stress. When we give stress, we also assess the soft tissue stability. So again, in that, the tightness decreased when we gave stress with lateral side opening, but medial side still being very tight. The computer told us what will happen if a certain plan is there, and then we'll see that we then tweak the planning to show how we want it so that we can work out. And you will see that in the both these things we have increased the VARS to 2 degrees to kind of ensure that our lines are equal and matching. This is how after doing the surgery the gap came in, and you will see that all the orange and purple are less than 2 millimeter, which is the accepted gap, and almost equal and above the line. So that's another case, and you will see a very well aligned knee in both the planes. This is a bilateral knee that we just did yesterday. In fact, less than 24 hours now. The patient is walking, is happy and relatively pain free. So these are few examples and how robotic replacement is changing the way we do even the complex cases. Of course, this has to be coupled with research, and we are doing multiple studies to show and improve the outcomes with robotic knee arthroplasty. This is one of my recently published paper in which we talked about how the technique, technology and the transition from our manual thing to robotic surgeries will happen. One question that people ask me is what will happen to surgeons? Will the robots completely take over? The people have illusions that it's the robot walking into the theater and operating. Patients ask me that, but I think ultimately the time has come where the man and machine will integrate itself. With technology, that's the case. We have all been used to our smartphones, and the life has integrated around the technology. And I think that is what will happen with the robotic technology as well. The surgeons and robot will work hand in hand, and the end point, I think it cannot be in an isolation. And this is a very beautiful commercial which I like to share. You see here, and it's the essence of where the robotic is happening. That ultimately it is about the technology when we can enjoy it, and I think the way forward is that all the elements, the technique, the technology and teamwork, they are all three of them are critical for success and optimal patient outcome. In isolation, nothing works. Newer technologies will help achieve our desired outcomes more efficiently and accurately. Robotics for knee replacement has brought about a paradigm shift in the way we think and perform our surgeries. People ask me, I'm a brilliant surgeon, do I really need robotics? And to that, my answer is, it forces an average surgeon to think, plan and become better, and even a good surgeon to introspect and adapt to the technology. At heart of all the technological innovation is the quest for excellence. Technique, common sense and good team are essential for an outcome. And last but not least, the picture abhi baki hai and the best is yet to come. And the best way to predict the future is to create it. And I think integrating research, newer technologies and way to improve the surgical outcome is the way we'll improve our future. I thank you for your attention, and once again thank all the IMA team members for giving this valuable opportunity to interact and talk to you. I welcome any questions that you may have.
Thank you, Dr. Bagaria. It was a very nice representation. I want to ask one question regarding if there is a bending of the knee.
Yes, ma'am.
And if you do robotic surgery, can the deformities can be corrected? The leg becomes straight?
Yeah, a very important question, Dr. Shah. For any surgery, whether it is robotic or non-robotic, our goal is to align it to mechanical axis, which is to make the knee straight. And of course, having technology, the experience comes number one, but technology helps it to us to achieve it in absolute accuracy. So a short answer is yes, it helps. A long answer would be yes. For any surgery, whether you are doing robotic or non-robotic, the attempt is to make it straight.
Any question from panel? Anil, any on the box?
No question in the question answer box.
So what will be the cost for robotic surgery?
So apart from our usual cost, we are charging for consumable, which is around 25,000 and 20,000 extra. So around 45,000 is an extra cost to the patient from the normal cost.
So that is included in the medical bills, or they remove those money?
No. So we have submitted the proposal to the insurance company because the robotic technology is relatively new. The consumables, yes, of course, 25,000 is included. The additional 20,000, sometimes the patient have to pay from pocket. Some insurance company are covering it, some are not. But I think with time, in couple of months, even those will be covered.
Shall we
No
move
questions
to yes.
in the question box.
Shall we move to next speaker, Anil?
Yeah, thank you very much, Dr. Vaibhav. It's always nice to listening to you.
Same here.
I think this is the
Excellent
third lecture with
representation.
No, same here. Same
Thank you
here,
so
sir.
much.
It's always a pleasure to meet you guys. Thank you so
you.
much. Thank you. Thank you.
Now the next speaker is Dr. Rishabh Nanavati. I request Honorary Joint Secretary Dr. Arvind Patel to introduce the speaker. Over to Arvind Patel.
Good morning. Am I audible? Good morning.
Yes,
yes.
Thank you very much, Dr. Usha Shah. It is my privilege to introduce Dr. Rishabh Nanavati, who is a consultant rheumatologist at Sir H.N. Reliance Foundation Hospital and Research Center, Mumbai. He has to his credit MD General Medicine and Fellowship in Rheumatology from PD Hinduja Hospital and Medical Research Center, Mumbai. He received his training in rheumatology as clinical assistant to renowned rheumatologist Dr. Nilen Shah. His expertise is in treating challenging arthritis, diseases of musculoskeletal system, and celebrity athletes. Today, we will hear from him interpretation of lab investigations in rheumatology practice. Thank you very much. Over to Dr. Rishabh Nanavati.
Good afternoon, everyone. Thank you, Dr. Patel, sir, for giving such a kind introduction. I will just share my screen. So good afternoon, everyone. I thank the Indian Medical Association and Sir H.N. Reliance Foundation and Research Center for giving me this opportunity to deliver a talk on World Arthritis Day. So the topic that we will be discussing today is interpretation of laboratory investigations in rheumatology practice. So first of all, why do we need labs? Labs are essential to support the clinical diagnosis. Secondly, to monitor disease activity. Thirdly, to monitor adverse effects to therapy, and also to check response to therapy. So as rheumatologists, the most commonly used tests by us on a daily basis are acute phase reactants, namely ESR and CRP. So these acute phase reactants are elevated in most inflammatory disorders. Normal values practically rule out inflammation. These acute phase reactants are helpful in the clinical assessment of disease activity and to check treatment response. So ESR, it is measured by the Westergreen method. Values of ESR vary with age and sex. So ESR in males is calculated by age divided by 2, and ESR in females is calculated by age plus 10 divided by 2. So in a male of 70 years, an ESR of 35 is normal, and in a female of 70 years, an ESR of 40 is normal. As we all know, our laboratories give a standard estimation of ESR, which ranges from 0 to 15 or 0 to 20, depending upon the lab. Hence, a value of 35 in such patients should not be considered as an inflammatory change. Secondly is the CRP. It has an advantage that it rises and falls rapidly, although it is a slightly costly test. Values of CRP are usually low in SLE. This helps to differentiate if the fever in SLE is due to disease activity from that of secondary bacterial infection. From this side onwards, we will go through a series of cases where we will understand that the interpretation of labs led primarily to a faulty diagnosis by the treating doctor. So the first case is that of a 12-year-old male child who presented to the physician with complaints of pain and swelling of the right knee and ankle joints of 15 days duration. There was mild fever present at the onset of symptoms. Query history of sore throat was present. He had high WBC counts, high ESR, CRP, and platelets. His urine showed albumin, which was trace. RBCs and WBCs were 8 to 10. His ASO titers were elevated at 400. His uric acid was normal. RA and ANA was negative. So he was diagnosed as a case of rheumatic fever, and on basis of which he was treated with injection Penidura and aspirin, to which he had no response. So when he presented to us on inquiry, he had a history of loose motions 1 week prior to the onset of symptoms, and he was treated for conjunctivitis also around the same time. So eventually his diagnosis was post-dysenteric Reiter's syndrome and not rheumatic fever. Patient was treated with NSAID, with which he completely improved. So the points to note about ASO titers are it is sensitive, but it is not specific for acute rheumatic fever. Normal titers helps to rule out clinically doubtful acute rheumatic fever, and high titers of ASO are usually seen after the second week and reach their peak after 4 to 6 weeks of streptococcal throat infections. And many of the rheumatologists in their clinical practice have stopped more Penidura than they have started. Second case is that of a 60-year-old lady who had complaints of myalgia of 6-week duration. She had mild proximal muscle weakness on examination, although there was no breathlessness or dysphagia. She had complaints of tiredness and weight gain. Her CPK levels were high, although her EMG was normal. And she was diagnosed as a case of suspected polymyositis, and the physician asked for a muscle biopsy. Being asked for a muscle biopsy is naturally concerning for the patients and the relatives, and that is when she presented to us. So on examination, she had cold intolerance, there was constipation, there was bradycardia, there was delayed relaxation of ankle jerks. Her TSH levels, which we asked for, were significantly elevated at more than 100, and she was hence diagnosed as a case of hypothyroid myopathy. She was initiated with thyroid replacement therapy with subsequent resolution of her symptoms. So the consent of the patient has been taken prior to showing this image. You can classically see mask-like faces, sparse eyebrows, and bagginess of the upper and the lower eyelids. So points to learn about CPK. High CPK with myalgia is commonly seen in inflammatory muscle diseases such as polymyositis and dermatomyositis, viral infections, hypothyroidism. Statins, which are very commonly used drugs these days, are an important cause of myalgia and CPK, and the history of which should be elicited in patients presenting with such complaints. So the next case is that of a 20-year-old male who had complaints of left knee synovitis of 3 months duration. Occasional low-grade fever was present. His WBC counts were normal. His ESR was raised. RA, ANA were negative. HLA-B27 was negative. Uric acid was elevated at 8.8. Hence, he was diagnosed a case of gout, and treatment was initiated with Xyloric 300 milligrams daily. 1 month later, his uric acid came back to normal. His symptoms. So as we all know, this was a case of a single joint involvement of chronic duration being 3 months. So he was diagnosed as a case of chronic monoarticular synovitis. For the diagnosis of chronic monoarticular synovitis, tissue biopsy is very important. So he underwent an arthroscopic synovectomy. The histopathology was suggestive of tuberculosis. His MGIT and gene expert was positive. He was initiated on AKT and he responded to the treatment. The fourth case is that of a 17-year-old female patient. She had complaints of 3 months. She had asymmetric arthritis of the large joints of the lower limbs. Her WBC counts were normal. Her ESR was slightly elevated at 52. Her rheumatoid factor, ANA and ASO titers were negative. Her uric acid was marginally elevated at 7.9. Again, she was also initiated with 300 milligrams of Xyloric. 1 month later, her uric acid came down to normal, but there were no changes in her symptoms. So when we examined her, there was skin and nail abnormality present. There was inverted commas dandruff present. So she was a case of psoriatic arthritis. She was treated with NSAIDs and methotrexate with gradual improvement in her symptoms. So here we can see the image where we can make out there was significant synovitis of both the knee joints and the ankle joints and psoriatic skin lesions which are seen over the knees, the shin and the foot. There was another psoriatic patch which we can see over the extensor surface of the right forearm and the scalp psoriasis which was initially called as dandruff. She also had classical nail abnormality, which we see in psoriasis. On the left-hand side, which we can see was pitting, and on the right-hand side was onycholysis. Here we can see just classical images of psoriasis over the extensor surface of the forearm and over the plantar aspect of the foot. And these are the another classical nail changes which we see in psoriasis, which is known as subungal hyperkeratosis. So points to note about uric acid, that high uric acid does not equate to having gout. Not all patients during an attack of gout have high uric acid. 10% of males usually have a high uric acid, but only 1 to 3% with high uric acid will eventually develop gout. 25% of the patients with psoriatic arthritis have high uric acid. If uric acid values are more than 10, secondary causes such as renal failure and malignancy, such as lymphoproliferative disorders, should be considered due to increased cell turnover. And please avoid uric acid estimation in children and young women. Coming to case number 5 was that of a 71-year-old female. She had polyarticular symptoms, spinal pain. She had inactivity stiffness, activity-related joint pains. She had significant, not much of early morning stiffness. Her counts, her WBC counts were normal. Her platelets were normal. Her ESR was normal for her age. Her uric acid was normal. Although her RA factor was slightly elevated, her ANA was negative. So she was diagnosed as a case of suspected rheumatoid arthritis and suggested DMARDs, which are disease-modifying anti-rheumatic drugs. So when we saw her, she had classical bony swelling involving the DIP and the PIP joints, which are also known as the Hipperdon's and the Bouchard's nodes. There was no synovial involvement of the DIP and the PIP joints. There were significant varus deformities present of the knees. There was crepitus on knee movements, and she had hallux valgus of both the great toes. So she was a case of primary polyarticular osteoarthritis and not that of an inflammatory disease like rheumatoid arthritis. So in this image, we can classically see the Hipperdon's node, which is involvement of the DIP joints, and the Bouchard's nodes, which involve the PIP joints. This is significant varus deformity. The patient had significant secondary osteoarthritis. So points to note about rheumatoid factor. Commonly used methods are latex agglutination, ELISA, and nephelometry. Rheumatoid factor is not specific for the diagnosis of rheumatoid arthritis. It is seen positive in 70 to 80% of the patients with rheumatoid arthritis, and it is present in a variety of rheumatic and non-rheumatic disorders, such as SLE, Sjogren syndrome, mixed connective tissue disease, polymyositis, cryoglobulinemias, sarcoidosis, chronic liver disease, chronic infections, malignancy, and old age. So old age population above the age of 60, 10 to 15% of which have a false positive rheumatoid factor. So what is the importance of titer? High rheumatoid factor titers increases the specificity for diagnosis. High titer generally indicates aggressive disease, and high titer eventually prompts early and more aggressive therapy. Anti-CCP antibodies, they have high specificity for the diagnosis of rheumatoid arthritis. It can precede the onset of symptoms by up to 10 years, and it is associated with most severe and destructive arthritis, both clinically and radiologically. Coming to case number 6 is that of a 32-year-old male who had complaints of low back pain of 3 months duration, which were progressively increasing in nature. He had early morning stiffness of 30 to 45 minutes, but the alarming thing was that he had fever and significant weight loss. His X-ray of the LS spine and the sacroiliac joints were negative. His ESR was raised and HLA-B27 was positive. So hence, on the basis of HLA-B27 positivity and low back pain, he was diagnosed as a case of seronegative spondyloarthropathy and treated with NSAIDs and physiotherapy. But there was no improvement in his symptoms. So when he came to us, we asked for an MRI of the lumbosacral spine and the sacroiliac joint, which showed significant marrow edema with involvement of the paraspinal muscles, significant involvement of the paraspinal muscles as well. So his MRI of the spine was suggestive of tuberculosis, and he was initiated on AKT and advised bed rest, and he gradually improved. So points to note about HLA-B27 positivity. that HLA-B27 positivity does not mean seronegative spondyloarthropathy. It identifies a genetic predisposition, meaning patients who are positive for HLA-B27 are highly susceptible to developing this kind of arthritis. In 85% of these patients are HLA-B27 positive, but of these, only a small percentage will develop seronegative spondyloarthropathy. However, it is important to note that HLA-B27 negativity does not rule out seronegative spondyloarthropathy. Case 7 is that of an 18-year-old female. She was investigated in an outside hospital for rapidly progressive anemia. Her Coombs test was positive. She was diagnosed as a case of autoimmune hemolytic anemia. She was treated with steroids, with which she responded initially. 6 months later, she presented again with intermittent joint pains, fever, oral ulcers. In a local hospital, she was treated with antibiotic, NSAIDs, and multivitamins, with which she responded. 2 months after her latest admission, she had abnormal behavior and seizures. Her labs were suggestive of low WBC counts of 3,200, low hemoglobin 10.2. Her platelets were 1,20,000. She had low complements. C3, C4 was significantly low. Her ESR was raised, which was 88. Her urine was active with 3+ proteinuria, 10 to 15 RBCs, occasional granular and hyaline cast, which was suggestive of an active nephritis. Her CT brain was normal. In the outside hospital, her ANA was done by ELISA method, which was negative. But when she presented to us, we repeated her ANA, which, as all of you all can see, was strongly positive, 1:1,003+ homogeneous. Hence, she was diagnosed as a case of SLE with autoimmune hepatitis, with autoimmune hemolytic anemia, arthritis, oral ulcers, and neurological and renal involvement. She was treated with pulse solumedrol and IV cyclophosphamide, and later kept on maintenance with mycophenolate mofetil, and currently she is in remission. Another case is that of a 45-year-old female patient. She had complaints of easy fatigability and hair loss. There was generalized musculoskeletal pain, weight gain, and constipation. Her routine labs were normal, but her TSH was elevated at 42, and her anti-thyroid antibodies were positive. To note is that ANA was also positive, 1:80. This is to show that ANA positivity can be seen in diseases other than rheumatological conditions. In this case, hypothyroidism. The next is of a 46-year-old female patient. She was a known case of TB lymphadenopathy on 4-drug AKT. 2 to 3 months post-initiation, she had complaints of severe polyarthralgia with pain and swelling of the ankles. Again, her routine labs were normal. Her ESR was raised 8.9. and her ANA was again 1:80 positive. So she was a case of hyperuricemia induced arthralgia, most probably due to pyrazinamide, and ANA positivity could be drug induced with isoniazid. So what do we learn from anti-nuclear antibodies? They are extremely sensitive for SLE, that is lupus, but not specific. Absence of ANA practically rules out SLE. Presence does not always mean SLE. Indirect immunofluorescence method is the gold standard for diagnosis. And there are various patterns which are seen on the immunofluorescence. Homogeneous, which is most commonly seen in patients with SLE, speckled pattern in Sjogren's and mixed connective tissue disease, and nucleolar pattern, which is seen in scleroderma. So ELISA is less sensitive. Immunofluorescence is the most sensitive and is the gold standard. So what is the importance of an ANA titer? So ANA titers of more than 1:80 are clinically significant and which requires further evaluation if the clinical features are present. Why is the age of the patient important? Like I mentioned before, in the case of rheumatoid factor, post the age of 60, 10 to 15% of the population can also have a falsely positive ANA. Drug history is also important, as quite a few drugs give rise to a positive ANA, but patients will not have clinical features suggestive of any connective tissue disease. And one of the most important things is when anyone is asking for an ANA test, it is important to know what is suspected. These tests should be asked only if the pre-test probability is high. Please do not randomly ask for an ANA test. So causes of ANA positivity are rheumatological disorders, non-rheumatological disorders, drugs, elderly age. Thus, a diagnosis of SLE requires more than just a positive ANA report. what are the problems that we encounter almost on a daily basis because of an unindicated positive ENA? So it is a source of concern for the patient and the relatives. It is a source of expense also because further tests are necessary. At times, it leads to a faulty diagnosis of SLE and initiation of unindicated therapy in the form of steroids and immunomodulators. Immunological markers of ENA, especially for SLE, are anti-dsDNA and anti-Smith muscle antibodies, which are highly specific for lupus. Coming to antibodies associated with antiphospholipid syndrome, which are procoagulant antibodies, which are seen in patients with connective tissue disorders, especially SLE, which include anti-beta-2 glycoprotein antibodies, anti-cardiolipin antibodies, and lupus anticoagulant. Now coming to anti-neutrophilic cytoplasmic antibodies, they are useful for the diagnosis of systemic vasculitis and glomerulonephritis. They are of two types, C-ANCA and P-ANCA. So C-ANCA, ANCA is usually used for the testing of small vessel vasculitis. C-ANCA, it stains the cytoplasm. Main target is the proteinase 3, and it is highly specific for granulomatosis with polyangiitis, formerly known as vaginous granulomatosis. And the other one is P-ANCA, which has a perinuclear pattern of staining. Its main target is the myeloperoxidase, and it is used in the diagnosis of eosinophilic granulomatosis with polyangiitis and microscopic polyangiitis. So eventually, what is most important is the clinical skill cannot be replaced by any laboratory or radiological tests. The take-home messages from this talk should be that pattern recognition helps in the diagnosis, make probable clinical diagnosis, and investigate accordingly. Please do not investigate to make a diagnosis. Indiscriminate lab investigations, which are unsupported by accurate clinical findings, often result in disaster. Don't be ruled by the lab, rule the lab. And as BMJ rightly quoted, that rheumatology is a clinician subspecialty. It is the last remaining heaven for clinicians. And I would like to end my talk by giving a vote of thanks to my mentors who have helped me a lot during my course of training in rheumatology. Thank you very much.
So thank you, Dr. Nanavati. Very wonderful information. Excellent presentation.
Thank you.
Yeah. Let me check. Any question from the panel?
There's one question in the question answer box. Can RA be a diagnosis with low R factor titers?
So what is more important than the laboratory are the clinical features of the patient, which include pain, swelling, and stiffness of the joints. There are 15 to 20% of the patients who will have rheumatoid arthritis and have negative RA and anti-CCP antibodies. So the diagnosis should not be made on the basis of the test, but on the clinical symptoms which the patient presents.
No more questions.
Thank you, Dr. Nanavati, for giving an excellent, wonderful information about the lab investigation.
Thank you, madam.
Usha, Dr. Usha.
Yeah.
I'll be just sharing a small presentation on our vasectomy center.
Yeah.
Dr. Jitesh Mehta, can you highlight by the time I start the presentation?
Yeah. Sure.
Yeah. So initially we had a family planning center over here at IMA Mumbai branch, and then due to some problems that occurred with the government and the payment problems, that center ultimately had to be shut down. And then we got an offer from the Poonawala's, Cyrus Poonawala and other Poonawala, and they were interested in starting a vasectomy center. They already have a vasectomy center in Pune, which is doing very well, and they wanted another center in Mumbai. They approached us because our premises were not in use that time. So we were thinking of doing something, and we got that offer, and we took that offer and we went in for it. So the whole center was absolutely revamped, renovated, and all the latest instruments, all the latest technology, whatever has been incorporated in it. It has been a very nice center, and of course we'll be getting the help from the Poonawalla Foundation, and we are going to start that center very soon, the next month. In fact, it will be from November. So Dr. Aspi Raimalwala is the chairman of that committee, and yeah, you can just listen to what Dr. Aspi has to say.
Voice, please. Audio. Raimalwala, your voice is not coming.
Your voice is not audible.
Audio, please.
Dr. Awad is not audible.
Unmute yourself.
पता नहीं आवाज क्यों नहीं आ रही है?
हाँ नहीं आ रही है.
Sir, I guess you can play it from another video player if you have.
I tried with.
Okay.
Raimalwala, unmute your. Audio, please.
Dr. Shah ma'am, we are working on that only. There is technical issue with the audio.
Okay.
So Dr. Aspi sir is saying almost the same thing which I told, that we are going to start this center.
There is absolutely no voice.
Not at all.
No, sir.
So the center will be open from morning 9 to 5, and there will be a doctor sitting throughout that time, RMO sort of a doctor, and whoever surgeons, if the patients come, we'll be calling in the surgeons to do the surgery. And of course, it will be like an open clinic also. So any other surgeon who wants to bring their patient here and do the surgery can do it, because the whole infrastructure is there over here. And whatever charges fixed by the center will be paid to the surgeon.
Can you listen now?
Can you hear me?
Audible hai?
No, sir.
Am I audible? Dr. Aspi is not audible.
Sir, if you can share the video to me.
Okay, now we can move on to the next, because
Yes.
there's some issue with the video.
I think we'll do it the next time.
Yeah.
Next time.
Now the next speaker is Dr. Puneet Mishra. I request Dr. Komal Chaitanya. I am a CGP member, to introduce the speaker. This is the last lecture. Over to Dr. Komal Chaitanya.
Thank you. Dr. Puneet Mishra is consultant rheumatologist at Sir H.N. Reliance Foundation Hospital and Research Center. After graduation, he did his MD in General Medicine from D.Y. Patil University. He then did his fellowship in rheumatology from PD Hinduja National Hospital and Research Center. He has received his training in rheumatology from Christian Medical College, Vellore, Tamil Nadu, and Norfolk and Norwich University Hospital, Norwich, England, UK. He is also a certified clinical densitometrist and has received his training from the International Society for Clinical Densitometry, USA. His special interest lies in complex connective tissue diseases, vasculitis, rheumatological emergencies, and intra-articular injections. He has published numerous research papers and case reports in many reputed Indian and international journals, and has authored a chapter in the Indian Manual of Rheumatology textbook. Today, he will be speaking on approach to joint pains, diagnosis and management of ankylosing spondylitis. Welcome, Dr. Mishra.
Dr. Awad, sir.
present today. Good afternoon. I would like to thank the Indian Medical Association for inviting me to speak today. I'll be talking on approach to arthritis and diagnosis and management of ankylosing spondylitis. So, our rheumatological diseases present to different specialties in different ways. For example, it may end up with a dermatologist with rashes, can end up with a physician with fever, can end up with a nephrologist with nephritis, and a neurologist with like a mononeuritis multiplex, and so on. As rheumatologists, we deal with simple problems like from tendinitis, bursitis to even complex diseases like vasculitis and connective tissue diseases. And we have so many tests available these days that sometimes it can be quite daunting to like how to assess these patients. But it is important to remember that rheumatology is mainly a clinical diagnosis. We put a lot of emphasis on clinical patterns, and rheumatology is a lot about pattern recognition, which is something that I will emphasize as we go ahead. Pain is something that I deal with day in and day out as a rheumatologist. So the pain origin can be articular, para-articular, bony, muscle, ischemic, neurogenic, and generalized soft tissue pains. I'll focus on articular pain, and I'm sure all of you all know about this, so I will quickly go through this. Articular pain bases on movement. The entire range of motion is painful. For example, if you have a patient who's having arthritis of the shoulder, all the range of motion will be painful. This is in contrast to a para-articular pain. For example, if they have a rotator cuff injury, then they would have difficulty in internal rotation and abduction. In articular pain, you would get joint line tenderness, and if it's inflamed, it would be warm and swollen. Inflammatory pain is typically more in the morning, associated with morning stiffness for half an hour or more, and gradually improves with activity and increases on rest. If the swelling is there, it's generally warm, and the inflammatory markers are generally elevated. Mechanical pain, in contrast, pains are more in the evening. There's no significant early morning stiffness, and improves with rest and increases on activity. If there is a swelling, it's generally cold, and the inflammatory markers are normal. So when we get a patient of arthritis, we assess in the way like, is it monoarticular or polyarticular? If it's monoarticular, is it acute or chronic? So acute monoarthritis, the number one diagnosis that we keep in mind is septic arthritis. Very, very important. Unless if you have the first MTP involvement, then that's gout. The other, obviously, the other differential is gout. Then you can have early inflammatory arthritis. So patient presenting with one joint involvement and gradually over time can develop other joint involvement. It can be traumatic or avascular necrosis. That's something now, AVN is something we are seeing so much more in this COVID era. Monoarthritis can also be chronic. So when you have something chronic, you think of TB, monoarticular inflammatory arthritis, pigmented velonodular synovitis, and osteoarthritis. Now, when you have a patient of polyarthritis, you think in two groups. You think whether the patient is predominant joint complaints more than any extra-articular and systemic complaints. If that's the case, then you think then it's more likely to be something like rheumatoid arthritis or spondyloarthritis. But if the patient has more of extra-articular and systemic features like rashes and fevers and other symptoms, you think of vasculitis or connective tissue disease. And as introduced, all about pattern recognition. So if you have somebody who has rash, multi-system involvement like proteinuria, fever, weight loss, and cytopenias, think of lupus. If somebody has a rash, like typical rash like this on the fingers called cotton papules with proximal muscle weakness, elevated muscle enzymes, think of dermatomyositis. If somebody has rash with multi-system involvement like pulmonary, renal, neurological, etc., fever, weight loss, and has cytosis, has high counts, has leukocytosis, thrombocytosis, think of primary vasculitis. So as I said, it's all about pattern recognition. Now coming to spondyloarthritis. So spondyloarthritis includes ankylosing spondylitis, psoriatic arthritis, reactive arthritis, inflammatory bowel disease, etc. So ankylose means bent and spondylose means vertebral disc. So that's where the name has come from. The clinical manifestations we divide into articular and extra-articular. Coming to articular, the most important thing is the inflammatory low back pain. So we suspect if somebody with the onset of back pain before the age of 40, it's a gradual onset back pain. Typically complains of alternating buttock pains. They wake up during the second half of the night, maybe 3-4 in the morning, with a lot of pain and difficulty turning their head, and get up with morning stiffness for half an hour or more. And as they get into the routine, they take a bath and all, and then they gradually are able to get into there and they feel better. There is no improvement with the rest, and they feel a lot better with anti-inflammatory. In contrast, mechanical pain can occur at any age. Generally is acute. They typically have been or something or done some activity and then the back pain occurs. There is no morning stiffness or nocturnal pain, and activity would increase the pains. Apart from the back, ankylosing spondylitis can affect other joints. It typically affects the lower limb joints. It is asymmetric. It affects the large joints. It is generally asymmetric in nature. So it's not symmetric like rheumatoid arthritis, which typically affects the small joints equally symmetrically, small and large joints. While ankylosing spondylitis is asymmetric, but it affects the important joints like the hip joint, knee joint, and that can be devastating for the patient. This is dactylitis. It is you can see a sausage-like digit kind of inflammation that is there. So there's inflammation of the entire digit you can see here of the toes. Enthesitis is inflammation of the origin and insertion of ligaments, tendons, or joint capsules. It is a characteristic feature of spondyloarthritis, and the classical area is the Achilles tendon and the heel. So as I said, the classical side is the heel and the Achilles tendon, and the other sides can be, you can get a golfer's elbow or a tennis elbow, and sometimes around the knee. Chest pain is something that's very important to keep in mind. Many of ankylosing spondylitis patients complain of rib pains, and they sometimes get evaluated for cardiac issues and other things, and that's very important to rule out. But it's important to keep in mind that the pain could be because of inflammation in the rib cage. So the pain is especially on coughing or sneezing, and it occasionally can be a presenting symptom of AS. With time, if the patient doesn't exercise, disease is not controlled, it can lead to diminution, the chest expansion can reduce and can lead to a restrictive lung disease kind of a situation. Extra-articular manifestation. Now, every patient of ankylosing spondylitis or suspect ankylosing spondylitis, we must ask for history, 3 histories: history of uveitis, psoriasis, and inflammatory bowel disease. The other manifestation include cardiovascular, pulmonary, and renal. I'm going to ask for history of uveitis. We ask for history of redness, but the patient may say, it becomes a little red, but that's not the history. It usually happens very acutely. It's typically in one eye, and it is very red, it is painful, and cause blurring of vision. That's photophobia. So the patient has a lot of discomfort, and they have to go to see an ophthalmologist or come to see a physician to get evaluated and see what's happening. Sometimes, so there's no correlation between the eye involvement and the joint involvement. Sometimes you can have the ankylosing spondylitis being very severe, but uveitis may not happen, or it may be mild, or vice versa. It's generally more common in actually B27 positive patients than B27 negative patients. This is a very important complication, as I said, uveitis, because if it's not well managed, it can lead to blindness. This, I'm sure everybody knows, this is psoriasis. Sometimes it may not be so obvious, so we have to really hunt for them. So we have to look at the nails. We look at things like pitting, crumbling, onycholysis. Look at the umbilicus for psoriasis, and look behind the ear. So we have to hunt for psoriasis. Inflammatory bowel disease, we always ask history of nocturnal diarrhea, bloody stools, if any problem of fevers, weight loss, or if there is iron deficiency anemia due to blood loss. joint to cardiovascular risk. So all ankylosing spondylitis patients, they have a higher cerebrovascular and cardiovascular risk compared to the normal population. The other cardiovascular complication like aortitis, aortic regurgitation, and conduction abnormality is very, very rare. Pulmonary manifestations, as I mentioned earlier, it can cause restrictive lung disease because of fusion of the costovertebral joints. But very, very important is that 30% of patients of ankylosing have obstructive sleep apnea. So always ask all ankylosing spondylitis patients if they have any snoring, daytime sleepiness.
Chirag, voice is not coming.
हैंग हो गया है.
हाँ. Anil, can you
Ring
hear me?
up the doctor.
Yeah.
Rishabh.
Chirag?
Yeah.
चिराग एक मिनट, चिराग ही गायब हो गया.
Chirag left.
We call him.
He's in the car.
Yes, I think my talk would hang. Sort.
एक माणूस को
नेट प्रॉब्लम होगा.
Hello. Sir, sorry for the interruption. Actually, the electricity stopped working, so the Wi-Fi and the internet gone. So I'm just reconnecting again. Sorry for the inconvenience. Is it visible, sir?
No.
This is a very important complication.
Not yet visible.
if it's not happening, I can share my screen and I can talk.
Shall I share the screen then?
If it's not happening, then I will share it. I will share it from my side and I can talk.
Yeah. Dr. Puneet, you're there online. Yeah.
Yes, I'm there online. So if it's not happening, I can share my screen. I can talk.
Okay.
I think it's better that
shall I
way.
share the screen?
Okay.
Ask Piyush to stop that.
Yes. So is my slide visible?
Yeah.
Yeah. Sorry, I'm doing it from the mobile actually. So.
It's coming. It's coming. Yeah.
Yes. So just regarding pulmonary manifestations, sleep apnea is a very important complication of this of ankylosing spondylitis, and we must always look for it. So daytime sleepiness, history of snoring, examine and look if you're able to see back of the throat. So there's something known as Malampati score, and just if you're unable to see back of the throat, think of obstructive sleep apnea. Coming to renal manifestations, it could be because of long-standing uncontrolled disease, so leading to amyloidosis, or because of chronic anti-inflammatory use, or even because of the disease by itself causing glomerulonephritis. Then osteoporosis. So ankylosing spondylitis patients are more prone for getting osteoporosis. Sometimes measuring BMD can be a challenge because the spine, there's a lot of ossification that happens, and this would falsely elevate the BMD and show better score, a better T score. So in these patients, just remember, we always take the spine with a pinch of salt. The more reliable is the forearm and the femoral neck. Coming to the investigations, X-ray, you can see here that there is fusion of the sacroiliac joints and there is the typical bamboo spine. But when we see an X-ray like this, we are already very late, and that's really a sad situation to be in. We can use, so we should try to diagnose by doing modalities like an MRI, which can pick up things much earlier. Sometimes the patient may be claustrophobic and may not be willing for an MRI. So we can think of doing a CT-SI joint. In the CT-SI joint, what we're looking for is basically erosions. So generally, if it is very early, a few months of disease, you may not see much of erosions. So if the patient has symptoms for more than a year or so, then it makes sense to do a CT-SI joint. Coming to HLA-B27, 90% of people who have AS positive, who have ankylosing spondylitis, have this gene positive. But also it's important to keep in mind that if I check 100 normal people who have no symptoms, 6 of them will have HLA-B27 positivity. So we diagnose ankylosing spondylitis based on sacroiliitis on imaging, along with one spondyloarthritis feature or HLA-B27 positivity with 2 or more spondyloarthritis features. And I will quickly again revise what are the spondyloarthritis the features are. So one is inflammatory back pain, arthritis, enthesitis, uveitis, dactylitis, psoriasis, inflammatory bowel disease, a good response to anti-inflammatory, family history of spondyloarthritis, HLA-B27 positivity, and elevated CRP. Now let's come to a case. So a 22-year-old male patient came with complaints of low back pain since 6 months with alternating buttock pain with early morning stiffness for half an hour, which is better on activity. He has a history of enthesitis, that's basically has heel and rib pains since 4 months. He's a smoker and his elder brother also has low back pain. On examination, his SI joint is tender and Faber's is positive. Now what is Faber's test? It's basically flexion, abduction, and external rotation of the hip, as you can see in the photograph here. And when we do this, and if there's inflammation in the SI joint, there would be pain in the back in that area. So on investigations, hemoglobin is on the lower side, WBC is 8,600, platelet count is on the higher side, and CRP is 24, and HLA-B27 negative. Now, it's very important to look at very fine things and very small things. So the platelet count is on the higher side. So something just keep in mind. The X-ray of the SI joint is normal. So what next? You have somebody who's having typical ankylosing spondylitis symptoms. His X-ray is normal. HLA-B27 is not good. It's normal. So the next thing that we do is an MRI. And in the MRI, we can typically see bilateral sacroiliitis, and we confirm the diagnosis of ankylosing spondylitis. So once we confirm the diagnosis of ankylosing spondylitis, the approach to our patient is that we assess the disease activity by using some disease activity index, and we assess the spinal mobility. The management, we divide it into whether it is axial involvement or it is peripheral involvement. For axial disease, physiotherapy exercises are very, very important. It is one of the most important things that we must tell all our ankylosing spondylitis patients. Apart from physiotherapy, doing things like pranayam to help for chest expansion is very important. Swimming is also a very useful exercise that they can do. And we must regularly emphasize on this. For axial involvement, anti-inflammatory is a cornerstone that we use on a routine basis, and there's something that's very important part of for management of axial disease. Disease-modifying drugs have a very limited role for axial disease. There is some evidence that sulfasalazine may work if it is used early on, and we do use it for cases, but it doesn't work very well. It will work only for mild cases, but not really for moderate to severe cases. And then obviously we have biologicals. For peripheral arthritis involvement, anti-inflammatory to buy time, but in these patients, we use disease-modifying drugs like sulfasalazine, methotrexate, leflunomide, and then obviously if things are really bad, then we go to biologicals. Then disease-modifying, so if we have a patient who has any extra-articular manifestations, like for example, inflammatory bowel disease, then again we use sulfasalazine, azathioprine, and who has uveitis, then we can use sulfasalazine, methotrexate. As I said, anti-inflammatory is very, very important. In ankylosing spondylitis, there is a way to use anti-inflammatory. In general, for example, for osteoarthritis, we tend to minimize our anti-inflammatory usage. We tell a patient, take a few days and we stop once you feel better. But for ankylosing spondylitis, that's not the case. So at least we must give a good dose of anti-inflammatory for at least 2 weeks. If there is no response, then sometimes we would change the anti-inflammatory. But it's important to give a good dose for persistent period for at least 2 weeks, because even though the patient may feel better after a few days, the inflammation doesn't completely go away. So it needs to be given in a proper way. Now, suppose if somebody has severe pains, requires a lot of frequent courses of anti-inflammatory on a regular period, then something that we must consider is biologicals. So the way I explain a patient regarding biological is that I give example of a diabetes patient. If you have a diabetes patient, we initially try with simple medicines, tablets, and we tell the patient for exercise. If things are not better, then we go ahead and we give insulin. Something similar for ankylosing spondylitis. We first try with our routine medicines. If things are really bad, then we go to biologicals. Biological has changed dramatically how we treat ankylosing spondylitis patients. It is very, very effective, and it's a superb option to have in patients who are having severe disease. So we have different groups of biologicals. We have TNF inhibitors like infliximab, golimumab, adalimumab, etanercept. We have IL-17 blockers like secukinumab, and now we have some oral agents, small molecules called JAK inhibitors like tofacitinib, which is still under trial, not approved as yet, but still under trial. Previously, biologicals were very, very, very expensive, but now we have biosimilars that have come in where the Indian companies have copied the original molecule, by which the cost of biologicals is on the lower side, and now many patients of ankylosing spondylitis can afford to take them. Biologicals is something that helps to not only control the disease, but also prevent the deformities and the joint damage. The workup for biologicals is this: we do the routine labs, CBCs, the liver functions, the viral markers, the MON2 test, TB Gold, and an X-ray chest. We decide on which biological to use depending upon a lot of factors. So we consider what are the extra articular manifestations. Does the patient have uveitis, inflammatory bowel disease? We take into consideration safety. So, for example, TNF inhibitors like infliximab have a higher risk of TB. So, if you're somebody who's diabetic and who's obese and has other risk factors for TB, we would tend not to use in these such kind of patients. Then coming to the third thing is obviously the cost, which plays a very important role, and then is patient preference. Like, for example, a patient may prefer to take it once a week or may prefer to take injection, which is once a month. So this is something that we always discuss with our patients. Let's come to a case. So a 23-year-old male patient, you can see there is hip joint involvement and also the sacroiliitis is there on the right thing. So if somebody, this case is important to know is that if somebody has hip arthritis, always look at the sacroiliac joint. The patient may just be having ankylosing spondylitis. There are patients who come there are patients who come to me after a hip replacement, and then we diagnose them retrospectively to have ankylosing spondylitis. Coming to the next case, I'm sorry about this. I'm presenting on the phone actually. So this is a patient of DISH, so diffuse idiopathic hyperosteosis, and you can see the chunky osteophytes. It's a very chunky osteophytes, thick flowing osteophytes that are there. Then this is in comparison to ankylosing spondylitis, where the osteophytes are very fine. Coming to the third case, a 32-year-old female patient complains of low back pain since 2 years, which is mechanical in nature, and started after her pregnancy. And you can see there is sclerosis of the iliac bone. This patient has osteoarthritis condensans alli. Coming to the next case, 38-year-old male with severe low back pain, predominantly left buttock pain, and poor response to anti-inflammatory. That's something which is very, very important. A patient with ankylosing spondylitis responds very well to anti-inflammatory. And on examination, there's left SI joint tenderness. So we got the MRI done, which showed left-sided sacroiliitis, and with soft tissue involvement, there was collection there. We got a CT gap biopsy done, which showed AFB positivity. This patient had TB. So we should suspect ankylosing spondylitis if there's inflammatory low back pain, where somebody has back pain less than 40 years of age, has alternating buttock pains, early morning stiffness with enthesitis, and family history of ankylosing spondylitis and psoriasis. Always ask for history of extra-articular complaints of psoriasis, uveitis, and inflammatory bowel disease. Look for subtle clues like thrombocytosis, CRP elevation, and always ask for MRI SI joint. In a young individual, we must always screen the SI joint. If we ask for MRI spine, the SI joint gets missed and we miss the diagnosis. So early diagnosis is the key to successful management. Average delay of almost 7 years in diagnosing ankylosing spondylitis. So the average delay is a lot. And this delay would lead to irreversible damage of the spine and other joints. When they Google ankylosing spondylitis, they see a man who is really bent and deformed. And the patient gets really scared. So that's what before they come to me, they have Googled everything and they get really scared. But I show them, I give the example of these two cricketers. One is Michael Slater on the left and Mcl Injury on the right. They both had ankylosing spondylitis. In spite of having this disease, they performed at the highest level in a physical sport. So we have very effective treatment in today's times, and it's important to diagnose and treat them appropriately. Thank you so much.
Thank you, Dr. Puneet Mashru, for sharing wonderful videos from your mobile. We are very sorry that our screen was not working, but we had managed it. So thank you so much. Any questions, Anil Awad, on the screen?
Yeah, there is one question. In ankylosing spondylitis, if patient is in complete remission on sulfosalazine, doesn't require NSAIDs, then when can we stop these drugs?
Yeah, it's a very good question. So ankylosing spondylitis is a chronic condition like thyroid or blood pressure. There's no cure. But if a patient is doing well, it's been a year and a half, and doing very well, then we can try to slowly taper down the medicines step by step in a gradual manner and see whether the disease comes back. Now, this always has to be a joint decision between the patient and doctor. And we need to tell the patient that this is going to be a trial and error method where we don't know at what dose the disease is going to come back, if at all. And so if the patient agrees, then we do give us, we try to reduce to the lowest possible dose. But at least if the patient has been in remission for at least a year and a half, 2 years.
Sir, exercise physiotherapy can't help after taking medicine?
That is a very important part of ankylosing spondylitis management, but it always comes as an add-on.
Okay.
As an add-on to the other therapies. So there are sometimes patients who are so mild that they just do physiotherapy and they are fine and they don't really get much of flares.
Sir, how long are biologicals given in ankylosing spondylitis?
Yeah, so it can be given long-term. There are patients who have been on infliximab for more than 10-15 years. And even with other biologicals, there's good amount of data, 5-10 year data that are available. So we can give long-term. In US and UK, the insurance pay for these biologicals, so they continue to take it for a long duration. In India, that's not the case. People are generally self-paying, so we generally give biologicals regularly for at least for 6 to 12 months, and then we try to space out the biologicals, try to reduce the dose or the frequency, and see how things go.
Side effects of this biological, sir?
Yes, it's a good question. So biologicals. There are different kinds of biologicals, and each biological has their own kind of a side effect profile. The TNF inhibitors, we have to be careful of TB. Though, like for example, as I said, infliximab has a higher chance of TB, while in TNF inhibitors only you have etanercept, which is the lowest possible chance of TB. So infections like TB are important to keep in mind. For IL-17 inhibitors, the TB risk is not really much there. But there's a slightly higher chance of getting fungal infections, upper respiratory tract infections. So infection is something that we keep in mind. I would just like to say that if you get a patient with ankylosing spondylitis coming to the physicians, and coming and following up, and you see them if they're getting weight loss, if you see that the disease is under remission, they are not getting much of back pain, but the ESRs and the CRPs are very high, just keep in mind for infection.
So thank you so much, Dr. Puneet Mashru.
Thank you very much, sir.
Yeah.
Thank you so much for inviting me, and I apologize for this.
Yeah. Thank you so much.
We should apologize because there was some problem with Chirag's electrical supply. It went off and he went off the program.
Okay, thank you. Now the last ceremony, I request Dr. Kajal Ahuja, Assistant Secretary, IMA CGP, Mumbai Sub-Faculty, to give the vote of thanks.
Kajal, 1 minute. As we do, I think last time also I shared with this good news. Friends, we all are aware that in the last program also we discussed this. These are some of the benefits of becoming IMA member. IMA is accredited by MCI to grant credit hours because that is the need of the hour. You should complete certain credit points for the renewal. Medical legal help also comes from IMA Mumbai branch. We have a PPS scheme. Then there are certain more benefits. But this is a very important thing I want to tell you, that we have reduced the membership fees, and this is the new membership fees. For single life member, it was 13,600. It will be now 11,565. And for couple member, it was 20,400. Now it is 17,256. This concession is only for 2 months, that is October and November. Those who are interested in becoming member, they can contact IMA office, Mrs. Josna, on 98-199-177-97. So friends, tell your friends also to become a member of IMA Mumbai branch. This is a golden opportunity. They'll be getting the membership And in the month of April, there will be a hike in the fees. Almost a 15% hike will be there. So that time the membership fee will go somewhere in the range of 14 to 15,000 for single life member. So take advantage of this concessional prices for the membership and make more members. I request even the panelists who are there, for the speakers, to take advantage of this thing. Thank you very much.
Thank you, Dr. Lalit. Now I request Dr. Kajal Ahuja, Assistant Secretary, IMA CGP's Mumbai Sub-Faculty, to give the vote of thanks.
Good afternoon, all. I would like to thank our speakers of today's webinar, namely Dr. Rajesh Minhyun, Dr. Pradeep Unut, Dr. Nilen Shah, Dr. Prashant Kamble, Dr. Vaibhav Bagaria, Dr. Puneet Mashru, and Dr. Rishabh Nanavati. I also thank our knowledge partners for the day, Sir H.N. Reliance Hospital, and thank Mr. Dipen Mehta, Mr. Piyush Kale, Ms. Vaishali Tanpure from DigiShield, who have given us the platform for this webinar, the technical details. At the same time, Dr. Anil Awad, President-elect, and Dr. Usha Shah, Assistant Director, IMA CGP, for conducting this webinar smoothly and efficiently. A big thank you to Dr. Pragji Raja for being MMC observer for today's session. Last but not the least, I thank you all the delegates for participating in this webinar in large numbers and making it a grand success. Thank you.
Thank you, everybody.
Thank you all.
Thank you. Bye.